for master's class. And then we are trying our best to cover a few main topics, which is quite famous for the exam. So this is among one of the very famous topic that I will cover. Is a typical versus atypical optic neuritis. So okay, I try my best to cover a few things, which is actually important in terms of those who taking care for the patient, and then we try to see what investigation we need to do, and then how we should approach this patient. Okay, of course, we expect there's a lot of differences in terms of presentation, but how are we going to cater all these things? So first, before we go further, we need to really understand what is optic neuritis. So I think by definition, it's quite straightforward. There's inflammation of the optic nerve. But most of the time, what we expected is you can see the swelling of the optic nerve itself. The appearance in the optic disc. But you must always remember that in some of the patient, the presentation may not be typical swelling disc. The disc may looks normal. Okay, what are the things? Other things that you should look for is reduce in vision, and you have to check for the color vision. Okay, so most of the time, patient presented to our clinic in the acute stage. That mean most of the patient may come within 1 or 2 days. Some will come very fast. Usually, it will not be so late. So it's quite easy to identify this kind of problems. Okay. So what we need to know now is what is typical, what is atypical optic neuritis. Okay. This is a common classification that I think almost everyone here know about it. Retrobulbar optic neuritis, papillitis, where you can see the swollen disc. Then neuroretinitis, which may presented with macular star. So where it stands most of the time. So what we can see here is actually most of the patient with typical optic neuritis may have appearance of normal optic disc, and some may have a little bit of swollen disc. So this is the range of presentation. But most of the cases which is atypical will presented with swollen disc. Okay, so that is simple guideline. So now we're going to look a little bit more detail what is typical. So usually in typical optic neuritis, how patient presented is most of the time is unilateral presentation. And then mainly woman, okay, lady, and then presented with visual loss, and some patient may presented with color vision defect. Okay, you should ask about painful eye movement because some of the patient may not complain because the pain is not so much. Unless the pain is very severe, they will complain to you. But most of the time, patient may present with just a discomfort during the eye movement. So, like I did mention before, fundus examination, in terms of optic disc, you should able to look into the disc, and most of the patient may present as normal appearance. Some may present with just a very mild optic disc swelling. So this is actually if in typical optic neuritis, most of the time, the visual outcome is very good. It will recover within, most of the time within few months. And then the role of IV corticosteroids, like been suggested in ONTT, will faster the recovery. But at the end, there will be no difference in terms of the final visual outcome. So in typical also, if you do MRI of the brain, you can see the presence of brain lesion, which is consistent with multiple sclerosis changes, but depend on the situation. Sometimes it may present very early, so you can expect the changes is a lot. Sometimes it's just very mild, and you won't be surprised if you can't see any changes in the MRI if you encounter some of the patient. Okay, so also known as idiopathic demyelinating optic neuropathy. So if you see here, 20% of multiple sclerosis patient present with optic neuritis, and 50% of multiple sclerosis patient suffer with optic neuritis during the course of the disease. Okay, so the relation is very close, and then depend on the when patient come to see you, but the most important, you need to make sure that the investigation to rule out the multiple sclerosis. Okay, so I won't go very detailed about multiple sclerosis, just a little bit to make sure that you can recall. It's a chronic immune-mediated disease of central nervous system, which usually affects young adult. Okay, so number of patients that affected in multiple sclerosis has been increased by years. Okay, ini world punya lah. 2.1 million in 2008 and 2.3 million people patient in 2013. So in Malaysia, is it very common? So if we see in terms of prevalence of multiple sclerosis, you can see here in our setup, the color is light blue. So light blue is just about 0.5, 0.5 to 1 maybe. So that is a very little actually in 100 population. So to see patient with typical optic neuritis is quite rare. That is the message. Okay. So when you see or encounter the patient, most of our patient we need to investigate further, because the rate of ataupun prevalence of MS is quite low here. This is per 100 population, per 100,000, sorry. So where is the high prevalence of MS? Is more in North America and also in Europe country, where you can see here per 100,000 population is quite high compared to our setup. Okay, so like I did mention just now, here is the estimated prevalence of MS. So in Asia dekat mana tinggi? Sebenarnya tak tinggi lah. Japan maybe lah. Japan tinggi sikit lah. But not really. It's about 7 to 16 per 100,000 population. More of East Asia semua tak tinggi sangat lah. Including Malaysia, even Thailand pun lebih kurang je lah. But if you see Iran is in west side of the Asia, the prevalence is quite high here actually. So when you encounter patient, you sometimes you need to know patient come from where, because the prevalence is different. So in our study, clinical profile for ophthalmologist, we encounter that very little patient having multiple sclerosis, and in fact, actually, we have more NMOs, neuromyelitis optica, compared to multiple sclerosis. And more than 50% of our ophthalmologist is actually is idiopathic. We can't find the cause actually. So we move a little bit to atypical optic neuritis. So when we say it's atypical, mean those cases which is not typical. It's quite straightforward. Then why all this thing happen? Because in our setup also, we just now I show you that 50% of our patient, we do not know the cause. Okay, so what may trigger all this thing is inflammatory process, infection. We need to rule out, which is quite high in our setup, and some systemic disorder, especially connective tissue disorder. And then the most important, you need to rule out also some related lymphoproliferative problems like leukemia and lymphoma, although it's not very common. So what are the etiology here? Yang common, so listed here, infection, we have to rule out TB, syphilis, some cases of HIV, but so far we don't have so many cases of related to hepatitis, and SLE is quite common. Sarcoid is less, and then others is a little bit rare. So we can do now more MOG, IgG antibody rated, but it's a little bit expensive. We reserve for patient which is having recurrent attack and quite bad condition. But most of the time the treatment is quite similar. Okay, in terms of atypical, compared to typical, is a little bit more common in male. It can occur between more than above 20 years of age and with up to 50 years. But sometimes you can find few patients a little bit elderly, which is a little bit confused to you whether this is ischemic ophthalmopathy or not. Okay, sometimes may presented in both eyes. The vision is quite markedly reduced, but the presentation usually a little bit slow. Okay, slow progress, so that the patient come a little bit late. Okay, then on presentation the visual acuity also is quite bad. We need to investigate further to rule out all the possible causes like we did mention just now. Then, if possible, we start the treatment early to prevent the visual loss. Okay. If we see in the fundus, of course, this is most of the cases is markedly swollen with very, very typical appearance of swollen disc for optic neuritis. Okay. So here we can see the difference a little bit between these two, so that you can take some guide when patient presented to you. Most of the atypical cases a little bit older. Okay, but sometimes we presented quite young also. The most important here is the optic disc swelling. Okay. Of course, when you check the RPD tu, kalau affected in one eye, it will be positive. Okay. And then the other appearance is quite similar, but in terms of presentation, patient usually come a little bit late because it's slow progress. Okay. So what you need to do to take the good history in terms of visual loss and also neurological history, because you want to rule out the typical form of optic neuritis, and then some associated neurological problems which may presented in multiple sclerosis patient. Okay, medical history, the comorbid, which is quite common in our setup. Now, maybe vaccination. Vaccination is a hot topic now. Do not forget to ask, but we can't relate 100% yet. We don't have evidence so much. But if you have, you can document first. And then, like I told you, demographic is very important. Recent traveling now is very, very critical. Most of us can't travel. Then social history, which is important also. So we have one patient actually reported because of the suspected to have optic neuritis following the vaccination. But it is interesting case. Patient presented with bilateral optic neuritis following the human papilloma virus vaccination. Young patient. Okay. So it may happen, but it's not common. Okay. Then we reported a lot is actually atypical optic neuritis in infectious disease, like especially tuberculosis in our setup. So we need to assess properly the patient, especially color vision. The vision might be very vast in terms of the presentation. Some patients still have good vision, 6.6, but the quality is in terms of brightness may be a little bit low. But some patients may present quite bad, may reach up to NPL sometimes. So do not surprise. The most important, investigate first, then we give them the possible treatment. In terms of presentation, common presentation is central scotoma and also paracentral scotoma. Sometimes patient may have cecocentral scotoma combination from the blind spot and central scotoma. So this is papillary reflex. Hopefully the video okay. In terms of RAPD, can see here dilatation of the eye in affected site. Okay, just one more time. Okay, see from the right side. Okay, left, right. Okay, left, right, dilated. Okay, so this is RAPD positive. Okay. So in terms of ocular movement, sometimes patient may presented with some restriction of movement, which is associated with the MS problem or NMO. Some may presented with diplopia and also nystagmus, but it is quite rare. So you can actually report this one. Okay, we have one case, NMO, we've presented with nystagmus and diplopia. Okay. Sorry. Okay, fundus, like I told you, in terms of typical, most of the time the swelling kalau present pun a little bit less compared to atypical, which is quite obvious swelling this. Like this, it's very, very marked swollen. if you do OCT also, you can see that this is really swollen. Okay. Then later you can have a thinning of the nerve fiber layer surrounding this. So in acute phase, kalau kita buat VEP, actually you don't need to do VEP. Cuma kalau buat, you akan nampak lah dia punya decrease in terms of the compared to normal. Okay, it may return to normal after patient recovered. Okay. So in terms of MRI, the whole optic nerve will be enhanced. So actually you don't need to do unless patient you suspect atypical. In typical, most of the time we don't need to do. But you may ask me whether we want to rule out MS or not. That is a very good question. Since patients still don't have any CNS punya presentation, most of the time tak perlu lagi. Because like I told you, our prevalence of multiple sclerosis is a little bit very low compared to the other Western world. So we don't need to investigate in all the patient for MS unless patient presented with CNS punya problem. Okay, in some atypical, you need to rule out optic perineuritis where patient may have MRI changes like donut sign and tram track. This is different presentation. Okay, it's quite interesting topic which we may discuss later lah next time. So this one we encounter also bilateral swollen disc in leukemic and lymphoma patient. So this is the series that we publish. Okay. So you can see it's more severe bilateral swollen disc. Okay. And then here you can see MRI showing that changes in the both eyes, both optic nerve, where some is having the optic nerve enhancement and some having the optic perineuritis changes. Okay. So neuroretinitis is different entity where you should suspect infective causes, which may occur in more than 90% of the patient. So more common is due to cat scratch disease. And then what are the challenges? Of course, we need to differentiate between typical and atypical. So what you need to do, you need to investigate further. Okay. So treatment for typical is quite straightforward. You can use ONTT regime. You can off after 2 weeks. But again, if you suspect MS, please follow up the patient. So for atypical, again, we need to find the cause. Unless you cannot find the cause, you may at least investigate already to make sure that if you want to start steroid, you are covered. That means patient do not have any signs of infective causes. Okay, so you may consider steroid, but you may alter ataupun you may adjust accordingly, depend on patient punya respond. So okay, again sama je yang tadi, typical and atypical. So in terms of summary, optic neuritis ni sebenarnya quite challenges jugalah. Sometimes you may think it's straightforward, but it's not really. So first of all, you need to differentiate between typical and atypical, because if you investigate further, you have to rule out causes like we did mention. So okay, sometimes you may not find the cause, but usually through slowly it will reveal. So okay, thank you very much. Okay, I stop here dulu. Nanti kita bila ada soalan, masa Q&A session. Okay, thank you.
Okay, thank you, Professor Wan Hasaba, for a very interesting and informative sharing about optic neuritis. Now, we will move on to our next speaker, who is our Neuro-Ophthalmology Fellow, Dr. Neuro I. Maston, who will be presenting about neuroretinitis, the challenges. I'll pass the time to Dr. I.
Speaker Ain. Mute tu.
Sorry for the technical error just now. Okay, Assalamualaikum warahmatullahi wabarakatuh and a very good morning. Thank you, Dr. Henry, for the kind introduction. We move to the next topic. Our next topic will be neuroretinitis, challenges in diagnosis and management. I hope this can give a clear picture and understanding about neuroretinitis and also can help you with your clinical practice later. So this is the outline of the talk. I'll give some introduction about neuroretinitis, followed by pathophysiology, then etiology of neuroretinitis, how the neuroretinitis commonly present, okay, investigations, management, a bit about ocular analysis study, and last but not least, a summary. So this is some introduction about neuroretinitis. Can you see the slide? Sorry.
No.
Hold on.
Tak boleh tengok. Tak ada.
Okay, how about now?
Yes, doctor.
Okay, so neuroretinitis was introduced by label in 1916. Actually, this label is the same label that introduced the label congenital emeresis and label hereditary optic neuropathy. So label found a patient with unilateral visual loss with this kind of fundus appearance, optic swelling and macular star. And he termed this condition as stellate maculopathy. It was about 50 years later when the FFA became popular after 1960. When Guest in 1977, he did FFA for the stellate maculopathy patient, and he found that actually in FFA, the leakage was actually from the disc and not at the macula. So he suggests to change the term of stellate maculopathy to neuroretinitis, means the inflammation started from the optic nerve. So this is the pathophysiology of neuroretinitis. Actually, neuroretinitis is an inflammatory disorder of optic nerve vasculature, right? Mainly at the prelamina or optic nerve head. In previous studies, they showed that from the FFA and ICG, actually there will be a massive leakage even if only single arteriole is involved. This is a bit detail about the pathophysiology. When there is inflammation of the optic disc vasculature, there will be exudation of the fluid and also the lipid and protein material to the peripapillary retina, causing macular edema. Later on, the fluid or the aqueous will pass down through the ELM, going to subretina layer, forming the subretina fluid. When this happens, the lipid-rich exudates remain in the outer plexiform layer, and due to the configuration of this outer plexiform layer or Henle layer, it can be seen as macular star. So this is totally different from the optic neuritis that Prof. Wan mentioned earlier, which the optic neuritis basically is the inflammation of the myelin sheath. Okay, this is inflammation of optic nerve vasculature. Okay, these are the list of etiology of neuroretinitis. It's slightly different from the optic neuritis just now because the pathophysiology also different. So in neuroretinitis, we can divide the etiology into infectious, inflammatory, and idiopathic. So for infectious, any organism can cause neuroretinitis actually. Any group can be the etiology of this neuroretinitis. But the most common, the Bartonella hensalae, which cause cat scratch disease, consists of about more than 2/3 of the etiology of neuroretinitis. As you can see here, other organisms such as TB, Salmonella, Toxoplasma, syphilis, Leptospira, and many viruses here, including the fungus and nematode, also can lead to neuroretinitis. So history is very important, whether the patient might get Bartonella or any other organism. Okay. Although the infection could be the major cause of neuroretinitis, this condition can be also a manifestation or due to inflammatory process in connective tissue diseases such as SLE, Behçet, IBD, polyarthritis nodosa, Takayasu, antiphospholipid, and also sarcoidosis. So again, history is very important because we don't want to miss all these conditions because of course, patient need a long-term plan for this. Okay, last but not least, the etiology of neuroretinitis can be due to idiopathic cause, okay, in which previous papers highlighted that about 25 to 50% no identifiable cause can be found, in which in this group, it can recurrent. Okay, so I will touch a bit about this etiology later on. Now we move to the clinical features of optic neuritis, of neuroretinitis. Commonly, patient will come to us with complaint of acute central visual loss. Okay, sometimes it can be accompanied by metamorphosia as well. So from our examination, we can see there will be swelling of optic disc, macular star, and cells in the vitreous in some cases. So this neuroretinitis can affect all ages, but it's quite common in the age of third and fourth decade. There is no gender predilection, but some studies shows more female predominance. So, like optic neuritis just now, patient may come with mild blurry of vision, or they might come with severe blurry of vision. In visual field examination, normally they will have central scotoma or supercentral scotoma, but they might also manifest with arcuate or altitudinal defects, and in some severe cases, they might also have a diffuse visual field defect. Okay, as we mentioned that the most common cause is cat scratch disease, so you need to see whether there's any evidence of, there's any findings that might suggest this cat scratch disease. Systemically, probably you can see the inoculation site, okay, the scratch site or the bite site, regional lymphadenopathy, which is commonly painful. Patient might complain with fever, malaise, or headache, right? In severe cases, patient may have more severe systemic manifestations such as encephalopathy, pneumonia, pleural or pericardial effusion, and endocarditis. So this one, the photo here is just to show you, this is what we call as BA. BA is bacillary angiomatosis. It commonly occur in immunocompromised patient. So if patient has this, so probably patient is immunocompromised. Okay, on fundoscopy examination, in early phase, when the patient come to us with blurry of vision, probably the findings could be optic disc swelling and macular edema. Subsequently, macular star will form after 2 weeks only. Okay, and then the macular star will resolve. It might take some time for it to be resolved. Okay, some changes can be seen up to 3 months or even 1 year. For the optic disc, after a single attack, the optic disc can regain a normal appearance if the attack is not so severe. But if the attack is quite severe, so the disc can be pale. How about if recurrent attack? In recurrent attack, normally the hard exudate won't appear as macular star, but it can appear like this at the peripapillary region. Okay, although from the explanation just now, it looks like straightforward. The neuroretinitis consists of optic disc edema and macular star, but you need to differentiate this condition from other conditions of optic disc edema with macular star. These conditions we call as optic disc edema with macular star. This could be due to malignant hypertension, papillary edema, NAION, diabetic papillopathy, BRVO, CRVO, or other things. Okay, this is for example, a child came with blurry of vision, but then ocular examination revealed that the patient had optic disc edema with heart exudates, quite extensive, and blood pressure examination showed that she has blood pressure of 240 over 160. She has a malignant hypertension due to few chromocytoma associated with von Hippel-Lindau disease. Again, history and thorough examination is important in cases of neuroretinitis. Optic disc swelling and macular star also can occur in papillary edema if it is severe enough. As we know, there are many causes of papillary edema, for example, space occupant lesion, intracranial bleed, intracranial infection, cerebrovenous thrombosis, or even like intracranial hypertension, which can be due to metastatic disease. Okay, this is the same. Okay, it can also due to NAION. You can see here optic disc swelling with macular star, in diabetic papillopathy, severe VMT, okay, there can be optic disc swelling with macular edema as well. Juxta papillary tumor or even infiltration, it can cause optic disc swelling and also macular exudation. So we go to investigations for optic neuritis. As I mentioned earlier, it is mainly caused by infective or inflammatory causes. So basically, most of the time it is caused by Bartonella henselae. So you can send investigation for Bartonella. But other than that, according to the history and for your suspicious, so you can send the investigations accordingly. Similar with the inflammatory causes, so probably you can send connective tissue workup based on your suspicious. Regarding the Bartonella or cat scratch disease, the serology is the ideal investigations. Okay, normally if it is positive for IgM, the value 1 in 12 or more, this strongly suggests active disease. Okay, but sometimes you can got negative IgM, although you highly suspect that this patient has Bartonella because the rise in IgM can be very brief. So what could be the option? So you can send IgG titers. So for IgG, if the level is 1 in 60 or more, it indicates the Bartonella infection. Sometimes it could be negative also because probably when we check the blood, the IgM return to normal before the IgG titers have risen. So what you can do is to repeat again the IgG titers after 2 weeks, in which for full rise in titer of IgG may suggest cat scratch disease, active or recent cat scratch disease. For Bartonella or cat scratch disease infection, other than serology, culture is rarely successful because this organism is a fastidious organism, a slow grower organism. Sometimes we can also send tissue biopsy if patient have significant lymphadenopathy, but normally the result will be non-specific. It only shows lymphoid hyperplasia and stellate granuloma. If we are lucky enough, so probably we can see the bacilli, which is positive in Wharton starry staining. Actually, PCR is the most sensitive for Bartonella. Probably we can send the aqueous or any other tissues. It's the most sensitive and reliable. It detects the 16S ribosome of the Bartonella RNA, but it is very expensive. How about neuroimaging? In neuroretinitis, normally neuroimaging is not recommended. Okay, we only proceed for neuroimaging if there is suspicious of cases like papillary edema or intracranial involvement. But some studies shows that when they study MRI on those patients, they found that there will be short segment enhancement involving the optic nerve head and also 4 mm of the optic nerve sheath. Similar with lumbar puncture, it is not commonly recommended for neuroretinitis, unless we suspect there is intracranial infection going on as well. How about the management? Okay, as we know that it is caused due to various infection or inflammatory process. So treatment is basically directed to the underlying etiology. Okay, I just want to highlight in cat scratch disease, Bartonella infection in immunocompromised patient. Okay, they tend to have a worse systemic and visual complications. So in these cases, so probably treatment need to be more aggressive. In severe cases of Bartonella infection like chronic bacteremia, like I mentioned just now, bacillary angiomatosis, endocarditis. So yes, of course, we cannot deny that antibiotics is important to cure the complications. But in mild to moderate cases, actually there is no randomized trial except this one. Okay, this best at all, they study the role of azithromycin in patients with Bartonella with lymphadenopathy. So what they found that the oral azithromycin may shorten the lead to significant reduction of the lymph node volume in 1 month compared to patients that are not treated with the antibiotics. So basically, in ophthalmology, this is the only study that we refer to for our basis in starting the antibiotics for cat scratch disease neuroretinitis. Okay, so again, for neuroretinitis, cat scratch disease, there's lack of a randomized trial, but just to make it easy, for mild cases, probably no treatment is indicated. For moderate cases, we can consider antibiotics. In severe cases, we can add steroids on top of the antibiotics. Okay, it is not wrong if we are not giving treatment in mild cases, because study shows that no difference in visual outcome between those treated and untreated in mild cases. But of course, as I mentioned, this is study mainly retrospective and some are from the case series. For moderate cases, yes, antibiotics can be given. Okay, it shows that antibiotics can lead to marked improvement in vision and it may lead to hastened visual recovery. Okay, and these are the antibiotics for cat scratch disease. Okay, you can remember the mnemonic DOPC, D-doxy, A azithro, R rifampicin, T or B Bactrim, C for Cipro. Okay, these are the dosage for doxy. Commonly in KKM hospital, it's quite cheaper, so we start at 100 milligram BD for adult. For azithro, 500 milligram daily, day 1, followed by 250 milligram daily for daily. Okay, for pediatric dosage, we need to adjust accordingly. So for pediatric, normally as first line, we give azithro because doxycycline can give some side effects, especially for children less than 8 years old. For severe neuroretinitis, okay, we can add on corticosteroids. Study shows that with addition of corticosteroids, okay, it shows that significant visual improvement compared to the group with antibiotics only. But as of course, like I mentioned just now, there is no randomized trial. There is no randomized study. This basically based on the retrospective study. So we can see the challenges in management. Okay, actually our guideline is basically based on the observations, small series and case reports only. So probably a better prospective multicentric study can provide a better information about the etiology, pathology, diagnosis and management of neuroretinitis, cat scratch disease. So this is a little bit about idiopathic neuroretinitis that I mentioned earlier, that it can be recurrent. So study by Sundaram et al. It shows that they can have bilateral involvement and most of the patient can have at least 3 attacks. Okay, so for these cases, their recovery is limited, visual loss is cumulative, okay, and then long-term immunosuppressive is recommended. So we need to be aggressive in recurrent cases of even idiopathic neuroretinitis. So this is the guideline that I mentioned just now. This is some study about ocular Bartonella. Okay, we have 2 studies in Malaysia. One is from USM. Okay, another one is from, sorry, it's not moving. Sorry, my slide not okay. The other one is from JB. So this about ocular batonellosis, not only neuroretinitis. Okay, so from the study they found that the mean age of the patients is about 20 something. Okay, the patient can have a mild to severe visual loss. For USM subjects, okay, they have more visual impairment compared to the HSA-JB. Okay, so this is both of the study found that females slightly more predominant compared to male, but in USM study most of them has unilateral, but in HSA they found more bilateral cases. Interestingly, in USM study there is no history of direct cat exposure compared to HSA-JB, and of course systemic symptoms occurred in more than 50% of the patients. Right. So neuroretinitis is the most common ocular finding in USM study, but in SHJB, although the neuroretinitis is quite common findings, but the most common finding are retinal infiltrates. Okay. So these are the treatment given for both studies. In USM, most of the patients are given azithro, while in HSA.C and whatever it is, at the end, the visual outcome is quite good. More than 2/3 of the patient has a good visual acuity 6/12 or better. So as a summary, okay, from this presentation, I hope I can highlight to you that there are many other differentials that you need to consider, although you think it is a neuroretinitis. So make sure it is not other causes of ODEMs. So to get good diagnosis, you need to have a history and clinical examination. So you can direct your investigations based on your diagnosis. So in cat scratch disease, okay, we reserve the treatment for moderate to severe cases. But other cases then cat scratch disease, for example, recurrent cases,
Beli ke tak payah beli?
or other than recurrent cases or like inflammatory cases, we need to more aggressive treatment is required. We need to treat accordingly. Okay, that's all from me. Thank you very much.
Okay, thank you, Dr. Ain, for very detailed sharing of neuroretinitis and the diagnosis challenges and management. Now we will move on to our next presentation, which is presented by Dr. Noor Fadila Muhammad, who is the consultant neuro-ophthalmologist from University Malaya. Her title will be Papilloedema, a systemic approach.
Assalamualaikum everyone and a very good morning. Thank you for the introduction earlier. I am not able to share my slides because the share button is not on.
Boleh try share screen tak, Dr. Fadila? Maybe kalau share tak boleh share screen. I think.
I do not think so. But can you hear my voice loud and clear?
Yeah, loud and clear, loud and clear.
Okay, right. But now I don't have the button to tick really. Let's see. How do I do it?
Can you see a three dotted? There's one button, three dots with three dots.
Yes.
You click that, and there's an option of share content. So
no, I don't have. I only have switch audio, connect to video system, and copy meeting link.
Okay. honor.
Here.
Dr. Ain, try to click Control, Shift and D.
Control, Shift and
D.
nothing happens.
Do you have this on the sidebar? There's a taskbar saying File, Edit, Share, View. Do you have that?
Hang on there. No, I don't have it. It cannot be because of I'm using MacBook. Can it?
That could be a possibility.
Yes, you have to go privacy settings now.
We can see your screen now, Dr. Fadila.
That's not mine.
Oh, it is not, yes.
MacBook, you have to go to settings and privacy, and you have to allow.
Yeah, because my share button, you got this like options at down below. I got mute, I got start video, and I've got share button there, but I cannot press it. Hang on there. Can you give me like probably a few minutes for me to resolve this, or do you want to continue with the next?
Sure. I think we can give Dr. Fadila some time. Maybe we move on to the Q&A session for the first two presenters first, before Dr. Fadila can resume her presentation. So I think some of the question was asked in the chat room, and Dr. Ain is trying her best to answer all the questions. So for those who have questions for the first presenter, Prof. Wan Hasaba, can also either put in the chat room, or I'll read it out, or you can ask directly through the WebEx.
Tanya direct je lah, senang.
Yalah, senang.
Apa-apa je lah. Tak kisah.
Yeah.
I mungkin tak boleh jawab semua, tapi tak apalah, kita try lah.
Hello, Assalamualaikum Prof. Wan.
Ya, ya.
Prof. Wan dan Dr. Ain. Saya Hadi.
Ya, saya kenal awak.
Prof. Wan, first of all, thank you. Thank you for your sharing just now, Prof. Very appreciate it. I have one question. Okay. Regarding optic neuritis, atypical optic neuritis that causes by infection especially. For example, syphilis, tuberculosis. Okay, in case kita dah diagnose patient with TB or syphilis or any infectious causes, we have to treat first kan. Then we can start the steroid later. My question is, when the best time to start the steroid, and any specific masa untuk start steroid? I mean, kalau dah lebih masa tu mungkin steroid dah tak membantu. I mean,
okay.
That's all, Prof.
Okay. Tadi, very challenging question.
Okay, thank you, Prof.
Okay. Soalan tu boleh dijawab secara ringkas dan juga boleh debate further lah. Okay. Guideline saja, guideline dulu. Okay. bila once you confirm there is a infective causes of optic neuritis, we need to treat the cause dululah. Let's say TB ke, syphilis ke, kita start the treatment. Okay, kita terus start the treatment as fast as you can lah. Okay, but after that you are thinking that whether you should start steroid or not, kan? Okay, so that is a common punya question lah. So you can start the steroid, tapi soalan dia bila lah, when is the best time, because the patient just started on dia punya regime, kan? Sebenarnya tak ada masalah. Once patient already started, even 1-2 hari pun you can start already the steroid, tak ada masalah. You can start early also, because at least dia dah covered. Because the treatment will take some times. Then the steroid, what actually the aim of the steroid is actually to help in terms of inflammation. So the cause of the inflammation in this kind of problem may be due to infective, and then you already cover the infective part, then you can start the steroid to reduce the inflammation. So hopefully after that patient will improve. Okay, then the next question pula is how much you want to give, whether you need to follow the ONTT punya regime or not, kan? Because this is not ONTT mainly is for typical optic neuritis dan idiopathic. It is not for infective causes. So this come the debate lah. Sama ada you nak bagi lama ke, nak bagi sekejap ke, nak follow ke, tidak ke. So it's open actually. It's open. Then you judge in terms of patient punya presentation. Usually what we did is that, this is from our experience saja, just to share. You may change accordingly. Kita follow juga ONTT punya regime. At least kita bagi 3 days. Kita monitor. Kita monitor ada improvement or not. From the first day patient started on steroid, then kita bagi time at least for 3 days. Then we assess back. If let's say the improvement tu sedikit ataupun almost tiada, almost none, but you think that patient may benefit a little bit more for high dose steroid, then you can give for another 2 days. Okay, so kita play around like that lah, up to 5 days. So after 5 days, biasanya you no need to continue. If the patient respond, it will respond. If the patient will not respond, it will not respond. So it will show lah by that. So after that, you can, if patient shows the response, you can continue oral as usual. But again, the question is how long you're going to continue. Most of the time, kita continue a little bit longer because we want to give time for the patient to recover. Okay, what are the regime? Usually every 2 weeks baru kita reduce 10 by 10 milligram. Kita start full dose macam biasa, 1 milligram per kg per day. Then for 2 weeks, then next 2 weeks kita reduce by 10 lagi. Altogether kita tengok respon. Some of the patient may be up to 3 months. It's a little bit longer. But along the way, you still need to monitor the side effect of the steroid. Make sure you check the blood profile, renal function, liver function, and at the same time monitor the blood pressure, the rest lah, semua sekali lah yang berkaitan dengan side effect of the steroid you need to monitor. So that should be the simple guide for you, but again you need to really assess the patient, make sure that side effect tu tak ada banyak sangat. Kalau the patient develop side effect a lot, then you kena monitor balik lah. You kena readjust the dosage of the steroid. So it is not straightforward answer. It's depend on the patient punya condition. Then you adjust pun accordingly. So I think that should be the way lah. Kita tak boleh nak cakap fix way of giving steroid. Okay, thank you very much.
Okay, Prof, understood. Thank you, Prof.
Okay, thank you, Dr. Hadi, for the question, and thank you, Prof. Wang, for the explanation. We're still waiting for Dr. Fadila to settle her.
Hi, Henry. I think I might be able to share now.
Okay,
Alright.
carry on. Okay,
Right.
thank you. Good.
Yeah, thank you.
So sorry for the technical glitch. Good morning,
Tak apa.
everyone.
It's okay.
Can you see now?
Can see.
Can you see the first one?
Yes. Yes, we can see. Yeah.
Okay. All right. Now let's just move on, yeah? Okay, the third topic for today is papilloedema and how you approach papilloedema systematically. Can you see my presenter view or can you see a full?
Actually, if a WebEx you use the presenter view, we are seeing the presenter view as well.
I see, okay. All right.
Yeah. So maybe a slideshow will do.
Yeah.
Better.
Is this better?
Yeah, this is better.
Okay, let me just close off so many other pop-ups. Okay, now papilloedema, right? Before I start with papilloedema per se, let's just go through optic disc swelling in general, because what you see first in the patient is optic disc swelling. Okay, so this is like a major or broad classification of optic disc swelling, which encompass all causes of optic disc swelling. So how I classify them is by dividing them into three main groups. The first one is optic disc swelling, where the visual acuity is affected. And this is more often than not is due to raised ICP, but it can also be caused by other conditions. The second classification is the optic disc swelling where the VA is affected. And this is mainly because of the disease of the optic nerve itself, what we call optic neuropathy. And the third group is optic disc swelling secondary to pseudo disc swelling. It's not a real disc swelling. All right. Right. So when you see the patient firsthand, how do you classify them into one of these three groups? So these are the things I always think about when I see patients with this condition. So the first thing is, of course, to see whether there is or there is no history of raised ICP. That's very important because you do not want to miss a patient with a brain disease or brain condition that can kill them, right? So you need to make sure that the patient comes without headache, without other symptoms of raised ICP. The second one is to make sure that the vision is affected or not affected. So that is very quick to do. You can do optic nerve function test in full as well. The next question is to ask whether this is a unilateral disease or bilateral disease, right? So this is also important. And the last one is to ask yourself whether this is a true or this is a pseudo swelling. So this is important because before you progress in your management of the patient, you want to make sure that you are going to the correct direction, right? You don't want to waste your time, your resources, chasing something to the wrong directions, right? So the first group just now, the first slide I showed you just now, optic swelling where the vision is not affected. So that is our main topic today. And under this, there will be papilloedema. I'm going to talk more about that later. Now, what are the etiologies of optic swelling where the vision is not affected? So the first one is eye disease. I'm sure all of you have seen this. Hypotony, for example, post-glaucoma surgery or post-trauma, where the intraocular pressure is very low, you can have this swelling. Non-ischemic CRVO, definitely you have that. Intraocular inflammation also can give rise to optic swelling. Next is optic nerve disease. Of course, any kind of early or mild optic neuropathy, you can have the vision being preserved, but the optic swelling is there. And optic perineal neuritis also can give rise to swollen of the disc, but the vision is somewhat retained, at least at the beginning of the disease process. Next group is systemic or metabolic diseases, malignant hypertension, we all know about this, and diabetic papillopathy as well. The vision is somewhat preserved, but they have, swollen discs. Right. And finally, our topic for today is papilloedema, which I divided into primary or secondary causes. Primary is, of course, what we call as idiopathic intracranial hypertension, and secondary causes like brain tumor, dural venous sinus thrombosis, hydrocephalus, meningitis. They can be drug-related, be lead poisoning. Right? But of course, there are many other causes as well. So have a look at this MRV, sagittal view of the brain. Perhaps you want to try and answer that in your heart, maybe. But there are two big arrows that I cannot conceal. What you are seeing here is a superior sagittal sinus thrombosis. You can see two thrombosis there. Look at the arrows. And this patient also has bilateral severe optic disc swelling. All right. So when you see them, you need to manage, right? So this is how you approach them. Of course, just like any other diseases, you need to begin with a thorough history, followed by examination and then investigations, imaging, and lumbar puncture. For this condition, bear in mind, remember this, never make mistake. You need to do imaging first, then only lumbar puncture. You cannot jump straight to doing lumbar puncture because the MRI machine is broken and you just want to do lumbar puncture first to see the opening pressure. You cannot do that, okay? Now, let's move on to the history. Transient visual obscuration is... transient visual obscuration is transient blacking or dimming of vision, and it can be related to posture. It was hypothesized to be due to transient vascular insufficiency of the optic nerve, right? So patient would say, sometimes my vision go down and it will just like recover by itself. I do not have to do anything. But some patient would say that it's related to their posture, or maybe for Muslim, when they are praying, when they prostrate, they would say, oh, suddenly it's all dark and it will come back again, right? They also can have blurring of vision, and this is because of induced hypermetropia. They can have double vision, what we call as a false localizing sign. And then headaches, very, very important. So headache, you need to ask everything about it. The intensity, how frequent do they get it, and what relieve it, what brings it on, and everything. But beware of the new type of headache. This is important, right? Patient has no headache and suddenly, since last month I've been having headache and it's so bad that when I cough, I have to hold my head. When I sneeze, I feel like holding my head because it's just get worse when I do that. So that's very important, very significant. Now, pulsatile tinnitus, or some people call it pulse synchronous tinnitus, is also important. It's a rhythmic, low pitch whooshing sound that they hear, and it's in rhythm. The rhythm is consistent with the heartbeat, right? And neurological symptoms inquire about whether there's any history of seizures, paraesthesia of the hands and limbs, of the legs, and any weaknesses or any change of sensation in the upper limbs and lower limbs. And ask about body mass index. Don't be shy to ask about this. Sometimes when you look at patients, they are a bit overweight, you're a bit like, okay, I don't want to ask because you don't want to hurt the patient's feeling, but that's wrong. You have to ask, okay? And the history of drug usage, like vitamin A, steroids, whether usage of steroid or withdrawal of steroids, tetracycline and oral contraceptive pills, and there's a lot more long list of drugs that can cause this as well. Now, and then you move on to examination. You divide it into systemic examination, followed by the ocular examination. Make sure the patient has got stable vital signs, there is no temperature, the heart rate is stable, and then measurement of blood pressure is very important because it can be the primary cause of the disease, but it can also be a reflex, what we call as Cushing reflex. So patient has SOL, for example, in the brain. It causes raised intracranial pressure, and this would stimulate Cushing reflex. Cushing reflex is a triad of high BP, irregular breathing, and bradycardia. So it can be the main cause of the condition, as in malignant hypertension, or it can be the reflex secondary to raised intracranial pressure, right? Now you continue doing the neurological examination. This is upper and lower limbs as well as cerebellar sign, and then you do ocular motility, very important. Look for force localizing sign, whether there is any signal palsy. And then visual field defects, look for enlarged blind spot, constricted field, scotomas. These you should do a confrontational visual field first, and followed by either kinetic or static visual field machines. Next, you move on to look into the eye, look at the optic disc, look for blood, retinal fiber layer, and any evidence of flame-shaped hemorrhages, whether there is dilated retinal veins or any obscuration of the vessels. Right. Next is spontaneous venous pulsation. I'm going to talk more about this SVP after this, right? And finally, of course, make sure that it is a true disc swelling, okay, and not a pseudo disc swelling. Move on to the investigation. Just like any other condition, you would do baseline blood test, you would do full blood count, liver function test, renal function test, ESR, CRP, but do it according to what the patient presents. Do not do everything under the earth, And then infection screening is also important. And then connective tissue disease screening, chest radiograph, right? So I just want to introduce to you 30-degree test, okay? You might, if you read about papilloma, you might see this actually. This is a very simple test, easy to do. You just need the B-scan machine to do it, just like when you do B-scan ultrasonography to look for retinal detachment. So it's the same thing. But what you are looking at is at the retrobulbar optic nerve shift enlargement. So in papilloedema, there will be accumulation of fluid behind the eyeball, right? So the optic nerve sheath would be widened. So you do this B-scan and then get the cut at the optic nerve, and then you measure the diameter, right? While the patient is looking straight ahead at primary gaze. And then you ask the patient to gaze laterally about 30 degrees. So what happens when the patient is looking straight ahead is that the optic nerve is in an S shape, remember? Right? The sinus shape of the optic nerve. When the patient looks to the side, the optic nerve becomes somewhat straightened, and this will push the CSF fluid backward. So what would happen is, if this is a true optic swelling, secondary to raised intracranial pressure, papilloedema, you would see reduction of the width of the optic nerve sheath. So any 15 degree, or some papers say 10%, some people say 15%, so about 10 to 15% reduction of the width is significant. Next, imaging. This has to be done urgently, if possible, same day, because you don't want the patient to develop coning, because coning can kill the patient, right? So, of course, ideally, the best is MRI plus MRV, a must do. Bilateral swelling, MRI plus MRV. But, most of the time you cannot get MRI, MRV on the same day. What's easier to get is CT and CTV. All right, so that is adequate. That can give somewhat similar qualities to MRI and MRV in detecting lesion in the brain, especially any venous sinus thrombosis. So what we are looking for in the imaging is, of course, any space occupying lesions, hydrocephalus. Look for optic nerve abnormalities, which include flattening of the globe. You need to look for optic nerve protrusion into the eyeball, optic nerve sheath enhancement, look for a meningeal enhancement to suggest meningitis, as well as empty sella. Then only you proceed to lumbar puncture. Alright, so you need to record opening pressure. This is very important. Once you already punctured the spinal and you forgot to do manometry, that's it. You have to repeat again next time, right? So and then the CSF analysis you send for biochemistry, microbiology, as well as cytology. And don't forget to send for Cryptococcus neoformans, cytology, and gram staining as well. And at the same time, of course, you have to do blood glucose level, right? You know that the CSF CSF glucose level is 2/3 of the serum glucose level, right? So that can aid you in making the diagnosis whether this is bacterial meningitis or not. And oligoclonal band, electrophoresis, you need to do serum as well as in the CSF, and then you can compare. Let's say if you get a level in the serum and then the level in the CSF, but the level in the CSF is so high, it may mean that the OCB in the CSF is being produced intrathecally. So it may suggest that the patient has got a CNS disease. Right, so next, let's talk about papilloedema. So what is papilloedema? Papilloedema is optic disc swelling due to proven raised intracranial pressure. So I highlighted the word proven there. Okay, so how do you prove it? Two ways. One is by imaging. When you do imaging, you can see large space occupying lesion, or there is evidence of hydrocephalus. The ventricles are all dilated. So that may mean that the intracranial pressure is raised. Second one is, of course, CSF manometry. Look at the opening pressure. What is the pathophysiology of papilloedema? There are about 5 causes. The number one is increased brain volume. This can be seen in SOL, hemorrhagia, abscess, or edema of the brain. Number 2 is idiopathic intracranial hypertension. Number 3 is when there is decrease in CSF drainage, right? So this can be due to hydrocephalus, meningitis, subarachnoid hemorrhage, dural venous sinus thrombosis, as well as extracranial venous outflow obstruction. What can cause this extracranial venous outflow obstruction? Conditions like large goiter, or if the patient has a big thyroid tumor, so they can obstruct the outflow. And the last 2 causes are rare, and these include decreased skull volume, what you see in cranial synostosis, as well as increased CSF production. Now, pathophysiology for this is we all know that optic nerve is enveloped by the optic nerve sheath, right? And within that, there is subarachnoid space surrounding the optic nerve, and this is continuous with the one is surrounding the brain. So the CSF pressure within the brain is directly related to the pressure surrounding the optic nerve. So when the ICP is raised, the pressure surrounding the optic nerve is also raised. So what happens is when there is raised ICP, it will cause autograde exoplasmic flow stasis. And this would lead to swelling of the retinal nerve fiber layer that would further compress the venules, causing venous stasis and venous leakage, and finally accumulation of extracellular fluids. Of course, if the swelling is long-standing, unresolved, not responding to treatment, for example, you can have optic nerve dysfunction secondary to optic nerve infarction. Now, these are fun facts to sort of like you have to remember. Okay, the first one is yes, almost all cases are bilateral for papillary edema, but it can be asymmetry. So sometimes if you see them really, really early at the process of the disease process, you might see that only one eye is affected and the other one not very convincing, something like that. But if you, after 1 or 2 days, you start seeing more swelling on the fellow eye as well. So usually they are bilateral, unless in a very rare case where you get a congenital stenosis of the sheath around the optic nerve, so that the fluid there is not that much. So it cannot transmit the pressure from the brain to the optic nerve, right? Second one, not all patients with raised ICP develop papillary edema. So this is interesting. So even if you think that they should have papillary edema, should have optic swelling, sometimes they just don't. Next, the degree of the disc swelling does not necessarily correspond with the CSF pressure. So it can be inversely related. Okay. And finally, dead disc can't swell. Okay, what does it mean is that once you get optic atrophy, you wouldn't have any swelling of the disc anymore. So if in a certain condition where you need to see whether there is a recurrence of swelling or not, like in IIH, right? You need to use other clues like spontaneous venous pulsation. Now, we are all very familiar with this scale, but this scale is very suitable for exam where you need to remember all this, and also very suitable for research purposes as well. But if you can notice that it talks more of the appearance of the optic disc, how much halos has formed, how much obscuration has been formed on the disc. Yes, you can use this because, it's more like an it's subjective, but it's also objective in a way. You give 3, it means this and this and that. You give 4, it means this and that. But I am more in favor of this classification because it talks more of the entire fate of the optic nerve following optic disc swelling, right? So you start with early and then followed by the established swelling and then chronic swelling, and then once it's resolved, what happens to the optic disc? So let's just have a quick go. Early papillary edema, you will see hyperemic disc. There's already bled margin, but if there was to be any SVP, it will be lost by this time, all right? So right from the beginning, the SVP is lost. See, it's to pulsate. Next is established. This is when you see more swelling and then more obscuration, and then the peripapillary light reflection is already lost. The retinal vein can be tortuous, and then you can start seeing some splinter hemorrhages, causable spots, heart exudates, and pattern sliding. Now, next, grading is chronic. This is when you start seeing some degree of dyspelor. The swelling is not that much anymore, but sometimes it's just like so raised into the intraocular structure, you call it as champagne core appearance. And this is when you can develop autociliary shunt as well. And post swelling, you can develop gliosis, and then sometimes it just don't go down, and then you will have permanent diselevation, and of course optic atrophy as well. Now, spontaneous venous pulsation. Spontaneous venous pulsation. Hang on there. What is this annotation? Spontaneous venous pulsation is defined as rhythmic pulsation of the retinal vein as it crosses the disc, and the pulsation is in time with cardiac cycle, right? With the systole and diastole. So this is caused by the difference between the intravascular pressure gradient between the intraocular retinal vein, the one that you can see in the slit lamp, and the retrolaminar portion of the central retinal vein, the part that you cannot see. So there's a pressure gradient. That's why the venous flow is always to the back, right? It only occurs when the ICP is below 19 cm water. So anything above that, it starts to cease to pulsate. So how do you examine them? You need to dilate the pupil. That's very important. If you are seeing through small pupil, there will be a lot of reflection and you cannot properly assess the pulsation. The best tool is, of course, to use direct ophthalmoscope because it gives 15 times magnification. Well, it's okay to use slit lamp. Yeah, you just have to increase the magnification, but you cannot use BIO. It is absent in about 20% of normal subjects anyway. So, how do you interpret the finding then? Right, so this is how. If it is not seen, maybe it is absent. Or maybe it is present, but the ICP is raised. Therefore, it stops pulsating. If it's seen, most probably the ICP is not raised at all. Right? Normal. There's no ICP raised. Or most probably the ICP is not raised at that time when you are looking in the eye. Meaning, at other time, the ICP can raise. Right? So in condition like IIH, you get sometimes fluctuation of the ICP. So maybe you are looking at that time when the ICP is not that high, right? So you can see the SVP, but other time, it's not that. What is inducible SVP? Inducible SVP means when you are looking at the patient, usually under the slit lamp, so you are holding the condensing lens, right? So you can use your middle finger or your ring finger to lightly, press on the eyeball, and then you see whether the SVP is inducible. So let's say if you can see the SVP, just with minimal minimal pressure, you can see the SVP bounding. So what does it mean? It means that the ICP is most probably normal or almost normal, right? Right, so let's move on to the most important conditions that we have to manage, idiopathic intracranial hypertension. So previously it's known as benign intracranial hypertension. I would like to urge everybody to drop this terminology. Do not call it benign intracranial hypertension. Everywhere elsewhere in the world, we have started using idiopathic intracranial hypertension because nothing is too benign about this disease. It can cause a lot of trouble to the patient in terms of symptoms of the headache. It can also give rise to, blindness to the patient if not treated properly, right? So some experts call it pseudotumor cerebri, which mean pseudo tumor, meaning it looks like there is tumor, but there is none actually. And some experts even call pseudotumor cerebri for a specific subgroup of IIH when the causes are like vitamins, when the patient has got some underlying causes to suggest this disease, you know what I mean? But I'm not in favor in this. I like everybody to just call this idiopathic intracranial hypertension, okay? Make it easy. Now, the association that you usually see is, of course, obesity, and and obstructive sleep apnea. So always ask the patient or always ask the partner whether this patient snores at night, whether there is any hypersomnolence during the daytime. Okay, and peak incidence, we all know this, is middle age, overweight, and childbearing women. The mechanism is not clearly known. According to idiopathic intracranial hypertension treatment trial, which was published in 2014, 98% women, 100% were overweight. You remember the BMI punya classification, right? So 100% were overweight, among which 88% fall under obese category. And 67% of these patients had obstructive sleep apnea. So that's very significant. Must be asked. Now, symptom-wise, headache, any kind of headache, they can tell you it's constant, they can tell you it's intermittent, it's pounding, it's pulsating, but more often than not, it's related to posture, right? Because posture can change the intracranial pressure, right? And they can also complain of pulsatile tinnitus, which is a low-pitch whooshing noise. They can complain of transient visual obscuration. They can complain of changes in the color vision. They can also complain of double vision, right? That's when they have raised intracranial pressure with false localizing sign on the sixth nerve palsy. Now, again, IHTT recorded 84% of their population of subject complain of headache, which was constant or daily. 68%, very high rate of transient visual obscuration, and 52% of patients complain of tinnitus. Now, what are the signs? They must not have any neurological deficit. That's very important. If they do have some cerebellar sign, do have some, shaky of the hands, some weakness of the legs, that is not IH anymore. You have to pursue towards different direction. They must have a raised CSF pressure. But some studies have found that some patients with IH, established, treated, they look like they should have the raised opening pressure, but they don't. So that's a bit confusing. So raised pressure is normally said to be anything more than 25 cm water, but I would say anything more than 20 to about 24 cm water is called borderline. So if the opening pressure falls within this range, so you need to look at other features to suggest IIH, whether it's strongly suggestive or not. They of course have bilateral swelling. They could have sixth nerve palsy as well, and they can have visual field defects. Again, classically it's enlarged blind spot, but in the end they can have a suppressed visual field, or the visual field becomes small, encouraging toward the center. In terms of investigation, a must. MRI and MRV, and what we are looking for, perioptic nerve sheath distension, globe flattening, optic nerve head protrusion, and vertical buckling of the optic nerve. The optic nerve becomes buckled, so if you take a proper cut near the optic nerve, you can see that it's actually like buckled upwards like that. And they can have empty sella, they can have narrow or slit ventricles as well. Lumbar puncture, the opening pressure is raised, the CSF has got to be normal, you cannot see any abnormalities at all, and other investigations are also normal. So these are normal people with raised ICP and a lot of problems with their headaches. Now, some of the MRI scans, there are arrows there, so you can imagine what this is. The first one on the left is you can see optic nerve head protrusion into the eyeball. You can see optic nerve sheath is enlarged. And then the picture on the right, you can see flattening of the globe. Can you see the posterior aspects? It's sort of like flattened. This one on the left, you can see the CSF curve around the optic nerve, normal. You don't see this. And then on the right, you can see buckling. That's what I meant by vertical buckling. It should just like go straight on this cut, but you can see that it's actually buckled. And on the left, you can see CSF field Salatosica, and this is empty-sella syndrome. On the right, it shows slit like a very narrow ventricles. So how do we treat these patients? First is of course medical treatment. The goal is to preserve optic nerve functions. Weight loss is very important, and this can be the only permanent cure, and this should be pursued aggressively by both you and the patient. Right? So you need to encourage them, lose weight, go on diet, start on exercises at the level tolerable by them. And then you cannot just tell them to lose weight because losing weight isn't easy. So you have to give them ways. One, maybe, introduce them to a dietitian, and then, exercise, introduce them to a support group, for example. All right. And you have to always ask them about their progress when you see them at follow-up until they get annoyed with you and, really go on diet. All right. Analgesic is important. You need to teach them how to take them safely because a headache can strike at any time. It's just like migraine sometimes. So teach them what are the side effects. Teach them about the maximum dose that they can take. Next, the star medication is of course acetazolamide. Diamox is a carbonic anhydrase inhibitor. It reduces the CSF production, and the initial dose, what we usually start is at 500 milligram BD, and then you titrate according to the symptom and the swelling. Yeah, but do not start it right after the lumbar puncture, because after the lumbar puncture, the CSF pressure would be low. That's why the patient has to lie flat for about 6 hours before the entire CSF replenish again. So you might want to start probably the next day. Well, that depends, right? And then you have to teach them about the side effects, monitor all the side effects of the carbonic anhydrase. In fact, you can use that to monitor the patient's compliance. Furosemide is a type of diuretic as well. This is not as effective as Diamox, but can be started on patients who cannot tolerate Diamox after a lot of persuasion. All right. Sometimes some people don't want to take Diamox because they get like numbness on the around the mouth, and that's very, you would say mild. So you have to persuade them to take them. So furosemide can be started at the dose of 20 to 40 milligram daily or PD. But of course, if you have an option of potassium sparing diuretic, that would be safer. Now, topiramate, I don't use it here in Malaysia because it has unproven efficacy. It can reduce the CSF production as well, but it can also reduce the appetite and treats headache at the same time. Now, what about IV methylprednisolone? So this can be given if you see the patient acutely and the swelling is so bad that the vision is affected, right? So for sudden severe swelling with macular edema, you can give this. The dosing is 250 milligram QID for 3 to 5 days. Of course, you can give 500 milligram BD or 1 gram daily as well. And then after that, you have to follow up with prednisolone 1 milligram per kilo. I usually taper over 4 weeks according to the sign and symptoms. Now, surgical treatment, optic nerve fenestration, is you can do this if the vision is mainly affected, more so than the headache, right? So good for papular edema, but it has little effect on the overall ICP, meaning you can reduce the pressure within encircling the optic disc, encircling the optic nerve, but not the main pressure within the brain, right? And of course, if not careful, you can make the patient go blind. It's a once only procedure, meaning you cannot repeat this. You only do it once and that's it. And unfortunately, it can stop working after 1 or 2 years, right? So how you do it is by creating a window or a slit in a distended sheet just behind the eyeball, and you allow CSF to escape into the orbit. This is to show you on the left, okay, you can see that it's a distended optic nerve sheet on the right, following optic nerve sheet fenestration on the right, and then it's already resolved. Interestingly, many papers have described that if you do it on one eye, the fellow eye would also be resolved. Now, other surgical treatments is of course shunt insertion. This is mainly if the headache is intractable, but the vision is not so much affected, so you would want to consider this, especially if you have been treating this patient for so long, so many complications. You may want to talk to your neurosurgeon and might consider this. So what you can do is of course VP, LP, or VA shunts. It can provide substantial relief to the headache by reducing the ICP. But of course, the complications are also many, which include meningitis, hemorrhage, peritonitis. Again, it will also stop after 1 or 2 years, but this one you can revise many, many times. You can replace it many, many times. Now, serial lumbar puncture, this is only a temporizing measure. In certain patients, you just have to do this. But remember that the CSF replenishes after 6 hours. So, it's really an unpleasant procedure to go. And because most of these patients are obese, so LP might not be too easy. They might need some fluoroscopic guidance to do this, right? But you may consider in an acute phase where the IH is so severe that the operating pressure is so high, so you may want to do it in a serial manner, right? So follow up, just like you're following up a glaucoma patient, perimetry at every visit. This is very, very important. What I normally do, I just do a Humphrey visual field and compare, and then look at the size of the optic disc swelling. Look at the size of the enlarged blind spot. And then you have to monitor the swelling, see whether it's reducing, whether it's getting more or not. You can even use the OCT to objectively measure the RNFL swelling. Blood test, if the patient is on Dimox, and you have to follow up this patient until the disease is completely resolved. Now, a little bit about pseudopapular edema. Why this is important is because they might confuse you. This that looks like swollen, but they are not actually swollen. So usually you see this on a routine examination. Patient can be absolutely asymptomatic. It can be unilateral or bilateral. Generally, vision is not affected, but sometimes they can have problems as well with the vision. Right? It has no clinical relevance, but can be a source of confusion. Right? How do they look? They have an irregular disc margin. They have elevation of the disc, but it's not beyond the disc margin. There is no obscuration of vessels. The vessels are not dilated. There is no hyperemia. There can be some anomalous branching of the retinal vessels. Okay, the RNFL reflexes, the circular ring of reflection is normal. Sometimes the cup is very small. It's even absent. The disc can be tilted as well, and then there shouldn't be any hemorrhages surrounding the disc. And what are the causes? The causes are, of course, the disc drusen, which can be superficial or deep, can be classified or non-classified, can be due to disc hypoplasia, tilted disc, crowded hyperopic disc, can be secondary to optic disc hematoma or myelinated nerve fiber layer, or it can be congenital anomalies. Right, so what you have to do, you can do A and B ultrasonography and look for hyperechoic drusens. You can do FFA, do the autofluorescence, and FFA would show that there is no leakage, just some staining around the disc. All right, and if you were to do CT scan, you can see some classification. And if you were to do lumbar puncture, you will see that the operating pressure is normal, then CSF analysis is also normal. Right, so this is just a photo to on the left is the B scan, which shows hyperechoic lesion, and on the right is the patient's fundus photo, which shows a drusen. Okay, that's all for this topic.
Okay, thank you very much, Dr. Fadila, for the very informative and very detailed presentation and the differentiation between papular edema and pseudopapular edema. So actually we are a bit lag behind time, but it's okay. So we will proceed with session 2 straight away, and maybe the Q&A session, we wrap it up after the second session presentation has been over. So now we'll pass the time back to Prof. Wan Hasaba for his presentation regarding AION versus non-arthritic AION. So, okay, Prof. Wan, I'll pass the time to you.
Okay, kejap. Boleh nampak? Okay. Can see, eh?
Yeah, very clear. Very clear.
Okay, good. Okay, kita continue lah. Okay, next topic is arthritic and AION versus non-arthritic AION. Okay. So this is the content of the presentation. Mainly we're going to compare because it's easy to understand if you compare these two, so that we know which one is actually arthritic and which one is non-arthritic. Okay. Okay. In terms of ischemic optic neuropathy, it can be divided into two forms. Anterior ischemic optic neuropathy, which involve the 1 millimeter segment of the optic nerve head, mainly the optic disc, and the result is that we can see the swelling of the optic disc. Okay, so and it's can be divided further into two, non-arthritic and arthritic, which is arthritic is mainly due to giant cell arthritis, which is quite rare. It's quite rare. Okay. And the posterior ischemic optic neuropathy, the ischemic that occur posterior to, selalunya belakang sikit lah, kalau tengok sini, along the optic nerve, which most of the time you can't see any optic disc swelling, and then it's difficult to prove this is due to posterior ischemic optic neuropathy. That's why the diagnosis selalu kita tak buat lah, because it's very very difficult to prove. Okay, it's more of presume. So we are not going to discuss too much about posterior. We're going to concentrate for the common one, anterior ischemic optic neuropathy. Okay, so which we know the supply, blood supply of the optic nerve head is from the central retinal artery, and also mainly due to from the posterior ciliary, short posterior ciliary artery, which supply this area optic disc area. So this is the normal appearance of the fundus. I think everybody boleh restore ni. So what we're going to see here, this is from our list. What we encounter in our clinic is that ischemic optic neuropathy is quite common actually. It's the fifth top in the list. Okay, so we're going to see more and more patients in future. Then this one you see which one that yang paling rare dekat sini is GCA. GCA so far kita tak ada banyak patient. Kita ada satu patient which is documented having problem. Okay. Why I highlighted this? Because this is to remind that this is a rare cause of anterior ischemic optic neuropathy. So if we see here distribution of the cases, neuro-ophthalmic cases, what I want to highlight here is actually this ischemic optic neuropathy comprise about 40% of 40% of all cases of optic neuropathy, which is quite large actually, quite large amount. Okay, so bila patient datang tu, especially in elderly, adult and elderly patient, you should think of one of the common cause is ischemic optic neuropathy. Okay, so straight away we compare here non-arthritic and arthritic. The incidence for non-arthritic is actually more per 100,000 population. Depend on the study, 2 to 10. Compared to arthritic is 0.36. So, which is very, very rare. Okay. The etiology, because the most common here, patient having all the systemic problem in non-arthritic, diabetic hypertension, hypercholesterolemia, which is contribute a lot in terms of the pathology. For arthritic, mainly due to GCA, more than 90%, and the age group is slightly different. For arthritic, is more than 65 years old, is elderly. So this one considered adult and elderly, then this one is more in elderly. For non-arthritic, male and female sama je. Then for arthritic, female is more. In terms of the treatment, there is no specific treatment for non-arthritic. We treat the cause. Okay. For the arthritic, it's due to GCA, mainly steroids. And then in terms of mortality and morbidity, is quite low in non-arthritic compared to high in arthritic group. Okay, if we look at here in terms of fundus appearance, you may see 360 swollen disc, but this swollen disc is compared to the optic neuritis just now is more towards palish because of the ischemic. Then, if you compare with arthritic, you read a lot, you can read that the appearance is whitish, where we call it chalky white appearance. Okay, it's due to prolonged or chronic ischemic. So in terms of field defect, this is typical field defect, inferior attitudinal field defect, which patient may presented in non-arthritic cases. Arthritic mainly generalized. So in terms of histopathological examination, but we don't do it here. This is from my previous supervisor, the late Prof. Cullen. So this is his slide showing that comparison between non-arthritic and arthritic. So if you see here in non-arthritic, there's one part, partial optic nerve ischemic here, compared to arthritic, the whole optic nerve involved. That's why we need to see in terms of the pathology how this happen and contribute to complication macam mana. Okay. In terms of non-arthritic, the vessel that supply the artery that supply the optic nerve is still intact, is still okay, compared to arthritic, where you see is filled up with all the inflammatory cell and then is blocked. That means it's chronic process where the whole supply to the optic nerve already obstructed. Compared to here in non-arthritic, the supply is okay. So that's why the theory of nocturnal hypotension come in. If you read a lot about non-arthritic ischemic optic neuropathy, that's another reason for the patient complain of sudden loss of vision upon awaking from sleep. Okay, because of the theory of the nocturnal hypotension. Okay, so we have a very small study here in our setup where we review all our patients with non-arthritic ischemic optic neuropathy. Most of the patients presented with sudden visual loss, like I told you, and the age group is 50 and above, with all the high risk factor, diabetic, hypertension, hypercholesterolemia, smoking, and patient have small disc. Some of the patient have history of sleep apnea, which is important for you to look up, and treatment with interferon and as you know, sildenafil also may cause some problem, which we cannot prove yet. So, but it's good to take the history, and then in terms of the prognosis is not really a good one. Patient remain, the visual acuity remain like that. Okay, this is one of our patient presented with inferior attitudinal free defect. Okay. Then some patient may present with circumferential swelling, but some of them may present with partial swelling. Okay, so you need to assess properly in terms of optic disappearance. Then during the follow-up, you can see the optic disc from swelling of the disc. Like I told you, the swelling of the disc here is more of a little bit more pale compared to the inflammatory one. Then slowly it becoming atrophy. Okay. If you follow up to 3 months, you can see the optic disc becoming pale. Okay, in terms of management, okay, so far there is no effective treatment for non-arthritic. Okay, what about anticoagulant? Okay, aspirin. So far there is no difference. The study shows no difference in terms of long-term outcome. And then about the anticoagulants which they use, which is a very small sample size that you cannot determine properly what is the outcome. Okay, and then some people use steroid. You are not wrong, but so far there's one reported study previously by High-Ray, which is a SIFU for the optic nerve supply. And however, this one is non-RCT study. It shows some early improvement in patient treated with corticosteroid. However, this is a non-randomized study. Later, one study by Saxena, double-blind RCT, shows that oral steroid show no significant difference in terms of the final visual acuity outcome between the two group, treatment and control group. So you can start, but you cannot promise anything to the patient. Okay. So in terms of arthritic, this is a very rare, like I told you before, mainly due to GCA, common age presentation, more than 65 years old. Quite a very bad visual loss. Then patient presented with systemic problem, polymyalgia rheumatica, fundus pale, pale more of chalky white appearance. Then investigation, ESR and CRP is sky high. How to confirm is through temporal artery biopsy. Okay. Then in terms of the treatment, the steroid may, the important is that to prevent the other eye. It's not to improve the current condition of the affected one. So you can see various patient where you can see here the optic disc is really pale in arthritic form of AION. Okay. So okay, if you have even one case also, you can report here because this is very rare. Previously we have one case here. You can see the temporal artery is quite prominent here. The biopsy proven, okay, and then this is the findings where patient presented with optic perineuritis. Okay. This is comparison between the inflammatory optic neuritis with ischemic and compressive. I think you can see here quite clearly. Ischemic is most of the time is unilateral. Some patient may have still good normal acuity because only certain part involved. Okay, common presentation is field defect. Patient may not recover fully. Partial maybe, tapi tak banyak sangat lah. In terms of optic disc, it looks pale. Okay, so the rest kita dah discuss about the inflammatory one. Okay, compressive depend on the condition. We are not going to look very detailed into this, but it's interesting to compare between the non-arthritic and arthritic AION. The age of presentation that I told you just now is a little bit younger in non-arthritic. Okay, the visual acuity is still there. Bilateral involvement sedikit saja. Okay, ada, not so common. Okay, ESR normal compared to arthritic. Systemic disease is quite prominent here. Treatment tak ada sangat compared to arthritic, of course, because of GCA you need to treat. Then recovery pun not that very good. Okay. So in summary, about 40% of optic neuritis cases ischemic form. Neuroimaging is not really required in order to establish the diagnosis of this kind of problem. Non-arthritic AION does not recover and there is no specific treatment. But like I told you, you may try patient on steroid, but do not promise anything. They expected to have some improvement, but the improvement may not more than usually less than 10%. Tak banyak lah. Arthritic, again, the treatment is with steroid is mainly to protect the other eye. Okay, compared to optic neuritis, recover with or without treatment. Okay, so this is a good message for, especially for those for all the trainees. Okay, thank you very much. We just discussed a very short one again. Okay.
Okay, thank you, Prof. Hasaba, for the detailed explanation of arthritic and non-arthritic ischemic optic neuropathy. Okay, we will move on to our next topic, who will be presented by Dr. Ai. The topic is entitled Visual Field Defect in Neuro Ophthalmology. So I'll pass the time to Dr. Ai.
Okay, thank you very much, Dr. Henry. Assalamualaikum warahmatullahi wabarakatuh. I hope the participants are still alert at this time. Okay, if you need coffee, please take some coffee with you. Okay, so our next topic will be visual field defect in neuro-ophthalmology. Believe me, this topic is very important because if you are clear about the understanding about this visual field, so your life will be much easier. You can get answer for the puzzle that's going in your mind. Can everyone share see my slide?
Yep.
All right. Okay, so this is the outline of the topic today. So I'll give some overview about visual field and how briefly how the visual field is mapped. Next, we go to visual pathway and go to the specific visual field defect. Okay, this is just some overview. Okay, visual field, actually we have binocular and also monocular visual field. Alright, each creatures has different binocular and monocular visual field. Okay, we focus to the human visual field. This is our binocular visual field. As you can see here, actually it is a superimposed visual field of the right and left. Okay, horizontally it extends about 120 for binocular, and at the temporal here is what we call as temporal crescent. This solely depend on the monocular. Right. On the center, it is superimposed of monocular, which we call as binocular. Okay, so superior and inferiorly, okay, like this, 60 degree superior and 75 degree inferiorly. Okay. But when we want to assess the patient, normally we check separately for each eye. So the monocular vision we describe as a trackway island of vision or island of vision surrounded by sea of darkness. It's not flat. Our visual field is actually like a hill with the peak of the hill located centrally at the central fixation or at the fovea. Okay, here is our blind spot. And using one eye, our visual field extends 60 degree nasally, 100 degree temporally, 60 degree superiorly, and 75 degree inferiorly. This is the basis of the visual field examination. But normally, we just map our visual field using this 30 degree central vision because actually 70% and more than 70% of our optic nerve fibers are located at the central 30 degree field. Okay, as a screening, normally we do confrontation, but if the patient can cooperate, it's good for us to perform a formal visual field test as this is reproducible. Okay, on the left side is GRM, one of the campimetry, and on the right side is Humphrey visual field, a perimetry. Okay, as I mentioned, it's only test for about maximum 30 degree. If you want to test a larger field, like we mentioned earlier, our field is up to 100 degree temporarily. So the test should be used is Goldman. But Goldman nowadays is not being used routinely because of technical issues. Okay, now everyone knows about this visual pathway. I don't go into detail about this, but just to highlight that our field that correspond to the visual pathway, for example, for the retina, the temporal retina correspond to the nasal field, okay, whereby the superior and inferior also the same. Superior retina responsible for inferior field and vice versa. Okay, it's even more complicated if we go further Okay, the retinotopic is quite complicated and that's not the focus of this talk today. Okay, now we go to the specific visual field defect according to the site. Alright. First, we go to RNFL and optic nerve. As we know, the arrangement of the RNFL is like this. Okay, the nasal fibers goes direct to the optic nerve, whereby the temporal fibers has a arcuate shape before it goes to the optic nerve. So, if there is lesion in the retinal fiber layers, okay, normally, as we know, the common could be glaucoma or retinal disease that affecting the RNFL, such as BRAO. But in neuro-ophthalmology, there are conditions that can present with this type of arcuate visual field defect. Okay, the conditions such as optic neuritis, NAION, and papilledema as well. It can be like isolated superior arcuate, it can be inferior arcuate, or it can be both. Okay, next, okay, as we know that there's also papulomacular bundle which comes from the macula itself to the optic nerve. So actually the papulomacular bundle is contains a lot of mitochondrial. I mean the RGC, the retinal ganglion cells, consists a lot of mitochondrial, and certain conditions it is a predisposed site of damage. Okay, so patient might have central scotoma like this, or paracentral. Paracentral means it doesn't involve the central fixation, but next to it, okay, within 10 degree. Some patients also develop psychocentral, means it extends from central to the blind spot. Okay, some common conditions occur, some common conditions with this visual field defect include toxic optic neuropathy, nutritional optic neuropathy, neuroretinitis that I mentioned in the first lecture, okay, because it affects the macula, okay, some optic neuritis cases, and last but not least, hereditary optic neuropathy. It's quite common for hereditary optic neuropathy because the RGC here is susceptible for the mitochondrial damage. Okay, so this is the example of the psychocentral, okay, due to neuroretinitis. When we give treatment, we can see that there is resolution of the psychocentral becoming central scotoma. Next, this is a case of labor hereditary optic neuritis. You can see from the father's photo, the right eye is more pale compared to the left. True enough, from the visual field, okay, this is the right eye visual field, okay. It has a diffuse visual field pattern, okay, whereby for the left eye, we can see it is psychocentral, means from the central fixation, it extends to the blind spot. Okay, like Profan mentioned earlier, okay, NAION can cause this type of altitudinal visual field defect, or we call as broad arcuate visual field defect, okay. Depends which segment, either superior or inferior short posterior ciliary artery involved. So if let's say superior short posterior ciliary involved, so the visual field affected will be inferior altitudinal defect. How about in papilloedema? Okay, this is the fundus photo of patients with at least grade 4 to grade 5 papilloedema. Okay, in the acute stage, we can see there will be enlargement of the enlargement of the blind spot. But in this visual field, other than enlargement of the blind spot, there is also nasal step present here at the nasal part. Okay, so here you can see the progress. If patient with papilloedema not being treated, so you can see the progress of the visual field defect from enlarged blind spot to nasal step, which extend further, causing diffuse visual field loss with optic atrophy. How about optic neuritis? Actually, in optic neuritis, any fibers can be affected. So any visual defect can appear in optic neuritis from enlarged blind spot, okay, arcuate scotoma, altitudinal, nasal step, or even diffuse visual field loss in severe optic neuritis. Okay, so secondly, we go to the chiasma. This is very important, okay, if you know the rules, so that will be easier for you to interpret. Okay, here in chiasma, there is decussation of the nasal fibers, okay, to the contralateral side. But the decussation will be different for the inferior nasal fibers and superior nasal fibers. Normally for the inferior nasal fibers, it will cross anteriorly, forming a loop at the posterior part of the optic nerve on the contralateral side, forming what we call as von Willebrand knee, whereby the superior nasal fibers and also nasal macula fibers may cross at posteriorly. Okay, so this is very important. Okay, and the temporal fibers doesn't cross. So, in anterior chiasm syndrome, based on our description just now, A, you can see that if the nasal fibers affected, okay, sorry. So if, yeah. Okay, alright, sorry. Okay, so A is here. If the temporal fibers is affected, so patient will get a nasal visual field defect for A. For B, if nasal fibers is affected here before decussation, so patient will get temporal visual field loss. If let's say only the macula fibers is involved before it decussate posteriorly, so patient may have visual field defect at the macula side. And when the von Willebrand knee is affected, on the left side, we can get a visual field defect for the left eye, but at the same time, due to decussation of the inferior nasal fibers, patient can have a right superior temporal visual field defect. Okay, this is to describe further with diagram. For example, in meningioma, if it compress direct to the von Willebrand knee, so patient will have left visual field defect with the contralateral superior temporal visual field defect. Alright, so in severe cases, if let's say it involves the anterior chiasm, for example, a huge mass here, so the left visual field can be lost, patient can have left NPL, and the right eye no more, like junctional scotoma, but it progress with diffuse visual field loss. Okay, how about nasal visual field defect? Actually, nasal visual field defect, 75% the cause is due to the intraocular causes, only 25% due to intracranial. For example, in this case, left heminasal field loss, actually due to NAION. But if bilateral, of course, although the most common due to ocular condition or optic nerve condition, but we need to rule out whether there is any other dangerous etiology. For example, like in this case, ICA aneurysm. So ICA is located at the medial part of the cavernous sinus, lateral to the optic chiasm. So when there is, for example, a huge aneurysm here, it might compress the chiasm, also compress indirectly to the other side of ICA. So compression of both of these temporal fibers may lead to binasal visual field defect. And of course, bitemporal is quite well known, commonly due to pituitary tumor. As we know that central pituitary tumor is, chiasm, central chiasm is about 80% most common. So if there is direct compression of the pituitary tumor to the optic chiasm, there will be bitemporal visual field defect. But at early stage, or in case it is not compressing totally the center of the chiasm, like in this case, a post-fade chiasm. So when the compression is at the anterior part, as I mentioned just now, the inferior nasal fibers cross anteriorly. So the patient may get only the superior quadrantopia, bitemporal superior quadrantopia, because only the inferior nasal fibers are being compressed. The posterior still okay. Okay, this one. On the other hand, if let's say the compression is at the posterior part, either due to pituitary tumor or craniopharyngioma, as we know the craniopharyngioma may arise from the pituitary stalk posteriorly. So the superior nasal fibers are being compressed, so patient may have inferior quadrantopia, bitemporal inferior quadrantopia. Okay, this is the summary of the chiasm lesion: bitemporal superior quadrantopia, bitemporal superior quadrantopia, bitemporal inferior quadrantopia. But as we know about the decussation just now, the central fibers or the macular fibers can be isolatedly involved. In apoplexy, sometimes patient can have complete blindness like this. Okay. So going to the retrochiasma, so after the optic chiasm, normally we have a mirror image of the visual field, the visual field defect. For example, like this homonymous, right homonymous hemianopia. It can be incongruous or incongruous, congruous or incongruous. Okay, we go to optic tract lesion. So this is a visual field, right homonymous hemianopia, which is incongruous due to left optic tract lesion. Specific to optic tract lesion, sometimes in chronic condition, for example, let's say compression, you can see based on the decussation just now, as we mentioned that the left optic tract, okay, carries the left fiber. So you can see this temporal pallor for the left eye, but for the right eye, as there's decussation of the nasal fibers and also nasal, the macula fibers. So you can see the bow tie atrophy. Bow tie atrophy because this is the pallor from the decussation of the papillomacular bundle or the macula fibers, nasal macula fibers, and this one from the nasal fibers that we discussed in the decussation just now. Okay, I hope you can digest whatever I'm saying just now. Okay, it's okay. Right. Now we move to the next part, the lateral geniculate body. Okay, lateral geniculate body is a part of thalamus. What is important here, you need to know that it has a dual blood supply. The posterior lateral carotid artery receive the blood supply from the posterior cerebral artery, whereby anterior carotid artery receives supply from the MCA. So this is the significance. Okay, this is the posterolateral carotid artery. Okay, just now. Okay, which gets supply from the PCA, posterior cerebral artery. It supply the central part of the LGB. When there is like, for example, ischemia because of this, so patient can develop horizontal sectoranopia. Whereby for anterior choroidal artery, okay, it supply the medial and lateral part of the lateral geniculate body, which correspond to the superior and inferior visual field. So in anterior choroidal artery ischemia, so patient may have this type like Pac-Man, quadruple sectoranopia. Patient may have unilateral or bilateral LGB lesion. Okay, so on the left side, there is a unilateral lesion. You can see, like we discussed just now. On the right side, if bilateral condition, there will be this type of visual field defect. We call as hourglass shape. Okay, for the A, okay, it is due to anterior choroidal artery problem bilaterally, whereby for B, lateral choroidal artery ischemia. Okay, next we go to the optic radiation. Okay, after the LGB, our visual pathway spread into a fan shape. The inferior fibers forming a loop, we call as Meyer loop. It goes through the temporal lobe, whereby the superior fibers going through the parietal lobe to the superior calcareous fissure. So if the Meyer loop is affected, it consists of inferior fibers, so patient can have pie on the sky, whereby if the inferior fibers are affected, okay, the superior fibers are affected, so patient may have pie on the floor. But this parietal lobe lesion, sometimes patient might have syndrome, complicated syndrome, okay. Even after stroke, they can have right to left disorientation, they can have aphasia, and a bit challenging to get visual field to be met for the pie on the floor. Okay. Like LGB, the optic radiation can have unilateral or bilateral lesion as well. Okay, if both the Meyer loop and also the superior fibers, if the lesion is quite extensive, okay, patient can have hemianopia. In this case, for example, the optic radiation on the left side is discontinued, okay. So we can see patient develop right homonymous hemianopia. In bilateral condition, if let's say the patient had right homonymous hemianopia due to the left optic radiation lesion just now, and on top of that, he also got lesion on the other side, so patient can have like this 3/4 visual field defect, which is mirror image. So this indicates retrochiasm lesion. Okay, this is another example. Okay, it can occur like, for example, traumatic brain injury or even multiple sclerosis lesion. Sometimes patient complain that they have difficulty in seeing the objects. So if we plot the visual field, sometimes although it is not very obvious, but if we look carefully, it is a mirror image. So this show or indicates bilateral optic radiation lesion. Okay, last but not least, this is occipital lobe lesion. Okay, the basic thing that you need to know is that this is the visual field. Actually, the macula area, it goes to the tip of the occipital, whereby the more periphery it is, the visual field, it goes further deep, okay, at the visual cortex. And one more thing is that the superior fibers, okay, actually ends at the superior part of the calcarine sulcus, which responsible for the inferior visual field and vice versa. So for example, you can see here 1 and 2. Okay, this is macula region, tip of the occipital lobe. Okay, the number 1 inferior fibers, it correspond to superior visual field, whereby number 2 superior fibers correspond to the inferior visual field, and the more periphery the visual field is, the correspond area will be deeper at the occipital lobe. Okay, so this is the visual field defect. It might affect the macula, the tip of the occipital or not. So if the tip of the occipital is preserved, so patient can have macular sparing. So this is to describe further. For A, the orange color here, you can see there is total right homonymous hemianopia, and the macula also involved. It is basically if, let's say, there is hypoperfusion, so patient can have this. For B, okay, there is macular sparing, green color here. Okay, normally if, let's say, the posterior cerebral artery is affected, but patient can have supply from the middle cerebral artery, so the macular area can be preserved. And the C is quite rare. It occurs due to distal emboli, which only affect the distal part of both artery, the PCA and MCA. Okay, the peripheral field will be preserved, only the macula area affected. Okay, this last but not least, temporal crescent syndrome. As I mentioned earlier, our binocular field at the peripheral part on each eye is solely depends on the monocular vision. So for example, if this deep occipital lobe is involved, okay, patient might have isolated temporal crescent syndrome. Okay, so I think you can figure out what could be the lesion. Okay, this one, the temporal crescent due to deep occipital. Okay, this one, temporal crescent is paired, okay, in left homonymous hemianopia with macula sparing as well. Okay, this one, the left homonymous hemianopia with macula sparing, and this one, only the macular area involved, means lesion at the occipital tip of the occipital visual cortex. Okay, you can study one by one, but I think you can go on your own. Okay, this one, some people got panic. Patient had very severe visual field loss. Okay, but actually, if you look carefully, this is a high false negative error, and the shape at the center here is a clover leaf pattern. Okay, this indicates that patient is inattentive. At the beginning of the test, probably he can plot at the central part, but he lost interest, and later on he sleep probably. Okay, and then what is this? This is due to ptosis. All right. So I think that's enough. As a summary, this is the summary. Okay, we can have prechiasm, chiasm, or retrochiasm lesion. For prechiasm, it can be unilateral, but when it reaches to the junctional area, so it can be bilateral involvement. Okay, for chiasm, it bilateral, commonly bilateral, but it is heteronymous, not mirror image. For retrochiasm, it is bilateral, homonymous, respect vertical meridian, which can be incongruous or congruous. Okay, I think that's all for now. Thank you very much.
Okay, thank you, Dr. Aing, for the interesting topic on visual field defect in neuro-ophthalmology. We know that this is quite a common topic for the trainees to know and master it properly during the exam, no matter whether you are part 1 or part 2 trainees. So visual field defect is a very important topic. Now move on to our last presentation, Fadila, on approach to pupil abnormality. So after this session, maybe we'll reserve 5 minutes for Q&A session for all the speakers to answer. For those who post the questions into the chat room, maybe the speakers can put it as well. But if you have any questions directly that you want to ask after this presentation, maybe you all can speak up. So now, without further ado, I'll pass the time to Dr. Fadila for her presentation. Dr. Fadila, we can't hear you. We can see your slide. You are muted, yeah, now you are unmuted. Yeah.
Can you hear me and see my slide now?
Now that there's no slide, but I can hear you.
Really?
Just now there was slide, but no sound.
Ananda, oh my dear. Okay, doing it again.
All right.
Again. What about now?
Yeah, we can see your screen. We can see your presentation. Maybe it's a spatial view. Yeah.
All right, I'm so sorry. Okay, hi again. Again, the topic is on approach to something, right? So you know that if the topic says about approach, it has to be wide and long, right? So I just have to justify my 1,000 slides. Okay, now let's just begin. Approach to pupil abnormalities. Proper pupil examination is very important for you to identify an abnormal pupil, right? So the prerequisites is you need to have a very good light source. So the quality that we are looking at is it has to have strong, steady, and focused light. Strong means the light source can be controlled by you. You can make it more intense or less intense. They have to be steady, meaning they don't flicker, as well as they have to be focused, meaning if you want to shine the right eye, you end up shining only the right eye and not the left eye. So we don't want the kind of torchlight that has rings after rings around the main source of light. So the best instruments are, of course, direct ophthalmoscope or binocular indirect ophthalmoscope. You can use your own torchlight if it has 3 qualities that I mentioned about. In terms of examination, you need to have a room where you can dim the light, and patient must focus well. So let's move on to the step for pupil examinations. These are the 5 steps that you have to do. I encourage you to follow the steps. The first one is checking for anisocoria. Second is the direct light reflex. The third one is a consensual light reflex. Next is the swinging light test, and finally accommodation. So what is a normal pupil? So normal pupil is usually round and located slightly infranasal to the center of the cornea. They constrict to light and they dilate in dark. That's normal, right? And the response must be brisk and not sluggish. And sometimes in some people, you see a lot of movement of the pupil, which called hippus, or it can also be called ectitosis. This is a constant rhythmic unrest of the pupil, irrespective of focusing on light intensity. And finally, the pupil must accommodate to near. Now, a little bit about the innervation of the pupil. It has both sympathetic and parasympathetic. Sympathetic will dilate the pupil via dilator pupillae. Parasympathetic will constrict the pupil using the sphincter pupillae. Now, so what are the abnormal pupils? Now that you know what is normal, what are the abnormal? So this is how I classify abnormal pupils, right? So the first one, they can be abnormal in shape. The second one, they can be abnormal in size. You know, one small, one's bigger, what we call anisocoria. And the third one, they can be abnormal in terms of response to light. Now let's move on to the first one, abnormal shape. This can be congenital and acquired. Congenital are conditions like aniridia, iris coloboma, persistent pupillary membrane. Okay. Oh, really? Okay, you go out. Can you go out for one? Oh my God. Okay, congenital conditions like aniridia, iris coloboma, PPM, persistent pupillary membrane, anterior segment dysgenesis syndrome, ectopia lentis at pupillae. So this is quite easy. You see them at a very young age, and there's nothing much you can do about it. Now, acquired conditions are like iritis, trauma, like secondary to injury or surgery. And finally, iris atrophy. Now, second types of abnormality is abnormal in size, anisocoria. So anisocoria can be physiological, can be pharmacological. If you dilate one pupil, and then you will see like one pupil is big, the other one is normal. And thirdly is pathology. This can be because of pathology, sympathetic or parasympathetic nervous system. When talking about pathological anisocoria, the lesions can either be in the eye, the orbit, the neck, or the upper chest. Let's move on to anisocoria. So these are the two questions that you would ask when you see an anisocoria. Question number one, is it the bigger pupil or is it the smaller pupil that is not normal? You don't know. If you look at the pupil, you wouldn't know until you do some maneuver to get the pupil to move, right? So the first one that you have to do is record the sizes in light and dark. So you use right eye, the left eye, and first in light. Because when you begin examining the pupil, you use your pen torch and put it down below on the face and shine both pupils at the same time. And then you really measure with ruler the sizes in millimeter. And then you off the light and you measure again, right? So the question is, which one is not normal, bigger or smaller? So if the degree of anisocoria is greater in dark, meaning when you off the light, the difference between the two pupils becomes more prominent, meaning there is a pupil that is not getting bigger. So that has got to be the smaller one. So it is a problem with the small pupil. Second, if the degree of anisocoria is greater in light, meaning when it is in light, the pupil has to go small, but now the difference is big, meaning there is a big pupil that doesn't want to go small, right? So it's a problems with the big pupil. Question number two that you have to ask or perform is to see whether the pupils react normally to light or react poorly. So what you do is you look at the pupil during the direct light reflex. If they react normally to light, most probably it's a sympathetic pathway. If they can contract normally in light, meaning the parasympathetic pathway is intact, so the problem could be in the sympathetic pathway. If they don't provided there is no RAPD, right? Because RAPD is the efferent pathway. We are talking about efferent pathway. If they don't, then the problem probably is in the parasympathetic pathway. Now, this is a table that I prepared to divide the classification of large people, small people, and how they react to light. So you can use this if you are asked during the viva, for example, or anytime when you see a patient. So the first classification is to divide them between small and large pupil, but they are not adequate because there you don't see physiological, because physiology, you don't know which one is big, which one is small, right? So for small people, it can be caused by Horner syndrome, agar-Robertson pupil, large pupil. Of course, there's oculomotor nerve palsy, the retinal palsy, there's tonic pupil, there's also traumatic mydriasis. If they react to light, normally it has to be the disease of the sympathetic nervous system. So it is either physiological or Horner syndrome. If they react poorly or non-reactive, it can either be retinal palsy, edystonic pupil, agar-Robertson pupil, traumatic mydriasis, or pharmacologically, when you put atropine, the pupil will not respond too well to light. I'm just gonna skip this, it makes me nervous. All right, now abnormal response to light. Okay, this is the type of abnormal response by the pupil when they respond abnormally to light. I further divided into whether they have normal vision or they have abnormal vision. If they have normal vision, it could be oculomotor nerve palsy, it could be ADs, it could be agar-Robertson, it could be pharmacology. And if they are abnormal, there has got to be RAPD, relative afferent pupillary defect, where the afferent pathway is affected, or amoretic, where the optic nerve is transected, there is totally no response, connecting the eye and the brain, so the pupil is large. Now, let's just have a quick look at special pupils' reactions. Right, so these are the things that most people are very fascinated about. So relative afferent pupillary defect, reverse RAPD, light near dissociation, as well as physiological anisocoria. So let's move on to the first one, RAPD. Why do people develop RAPD? This is apparent when there is a weaker optic nerve in one eye compared to the fellow eye. So you have got to have two eyes, but one is weaker. Right? It can be unilateral or it can be bilateral. And if it is bilateral, for you to see RAPD, the damage has got to be asymmetry. One is more than the other. Now, the location wise that can brings on RAPD is from retina all the way to in front of the LGV. Because as you know, the pupillary pathway travels from the retina to the optic nerve, optic chiasm, optic tract, and escape the LGB and then go straight to the pretectal nucleus. That's the first order neuron. From pretectal nucleus, it goes to the antigen-westphal nucleus, and from antigen-westphal via the third nerve to the ciliary ganglion, and from ciliary ganglion to the iris. Okay. Next, what are the main causes of RAPD? Of course, is the optic nerve itself. Right, problem with that, what we call as optic neuropathy. Or you can also have RAPD when there is generalized macular retina diseases. So how do you remember? The mnemonic is NIGHTIC. The etiologies could be secondary to neuritis, ischemia, infiltrative, hereditary trauma, toxin irradiation, as well as compression. And of course, to complement your RAPD examination, you have to complete all the optic nerve function tests, which are vision, visual field, color vision, red, brightness, and contrast sensitivity. Now, just have a look at this schematic drawing of a patient's eye. There are three sets of eye, top, middle, and bottom. Have a look at the top one. That is how the pupil looks like without any light being shown into the eye. Now, this middle one, when you shine the light onto the left eye, you can see that both are constricting. You get direct on the left, you get consensual on the right. So that's normal. So when you swing the torchlight, the light, quickly to the right eye, it has to be done quickly in order to prevent pupillary escape. to the right eye, and you can see that the pupil start to dilate. This is because the afferent power of the left eye is stronger than the right eye. So this is what a relative afferent pupillary defect on the right eye looks like. So remember Prof. Wan's video just now, it showed very beautifully how RAPD looks like. All right, so I'm sure everybody know about this. It's just that sometimes when you do it on patient, you can get a little bit confused, right? So all you have to do is just calm yourself and rest for a while, let the patient close the eyes and repeat again. Now, so quantification of RAPD. Do you need to quantify RAPD? Well, once in a while you need to. I don't really care about quantifying the RAPD because as the moment the patient has RAPD, I know that the optic nerve is affected. You want it or you don't want it, you still have to investigate and you need to treat the patients, right? But in certain conditions, you need to quantify. So of course, we have the neutral density filter where you can sort of like objectively quantify the grading of the RAPD. There's a lot of grading if you read the literature, but I like this one because it's simpler. So you have 1+, 2+, 3+, and 4+. And then I'm sure you can see on the table there 1+, when you see initial constriction, then only the pupil start to dilate. 2+, there is no constriction, the pupil just stay and then become bigger. 3+, when there is the pupil will immediately dilate, and 4+ is a moderate pupil, it's already dilated. Now, this is a neutral density filter. It's a very handy instrument, I would say, pocket size. It contains filters typed on a bar, and it has a density of 0.3, 0.6, 0.9, 1.2, 1.5, 1.8 log unit. So 1.8 is the darkest one, if you can see. I don't know whether you can see my cursor or not. This is the one. 0.3 is here. So when do you need to use this? When you do study, research, of course you have to do this because you have to quantify and it has to be reproducible, right? But in certain situations, when you are not sure whether there is or there is no RAPD, and you have to treat the patient, but you're not sure there is trace or no trace, 1+ or what. Usually when it comes to 2+, you will not make the mistake anymore. But it's 1+ or trace, sometimes some people might miss it. So what you can do is you take this density filter of the 0.3 log unit, the lightest one, and then you put it before the eye that you suspect to have RAPD, before that eye, right? So 0.3 in a normal people will not bring on RAPD. So if you are normal, you put it before one eye and you do swinging light test, you will not get RAPD. But now if you put it on the eye that has RAPD but cannot be seen very clearly, it will accentuate the RAPD. So if you put there and you do swinging light test again, and it will become more permanent, yes, you become more sure that there is RAPD. Now, how do you quantify RAPD? To quantify the amount of RAPD to get the equivalent grading in 1+ or 2+ or 3+, you put it before the normal eye. So you know that, like, let's say the right eye has got RAPD, you put it before the left eye and you do swinging test and you increase the density filter until the RAPD is neutralized. Now, reverse RAPD. Some people are very fascinated about this, but believe me, it's always present in an eye with RAPD. When there is RAPD, there's always a reverse RAPD as well. You are just not looking at it, right? So I'll explain more about this. So when do you need to do a reverse RAPD? You know that when the pupil is not responding, certainly due to trauma or some defect, some inflammation, some posterior synechiae, for example, the pupil is not responding, but you need to check whether the efferent is intact or not. So you do swinging light test, or some people might prefer to do torchlights. You can do either. I personally like swinging light test because it's simple. I don't need another extra pair of instrument. So this is exactly the same patient, the same pictures that I showed just now with RAPD on the right eye. Alright, what I change here is that I put the red mark on the right pupil, indicating that the pupil cannot be seen. The pupil is stuck down for some reason. Alright, so look at the middle set of picture. When you shine on the left eye, you see that the direct light reflect on the left eye is intact. On the right eye, there's no response, nothing. So when you swing the light quickly to the right eye, of course you wouldn't see anything, right? But because if there is RAPD and it's weaker in terms of the afferent, so the left eye would dilate, right? So in reverse RAPD, instead of looking at the right eye, which we normally do in a normal RAPD testing, we are now requested to look at the left eye. So since the picture is same, exactly similar to the one that I showed just now, so would you believe me that the reverse RAPD is always there when there is RAPD, only that you are not looking at it. Now you have to direct your attention to the fellow eye because that eye is not responding. Now, if you were to do the two torchlight technique, probably it will be easier because you put a light under the patient's face down below, shine both pupils, and then you will see that the left pupil start to dilate. But since I'm using the swinging light test, what I see is when I swing from the left to the right, alright, and then I swing back to the left, if that pupil constrict, meaning there is RAPD, meaning when I move from the right to the left, when I was at right, the pupil on the left was dilated. So now I swing to left, I would see the effect of dilation, but because there is direct, the pupil starts to constrict. So if I see that the left pupil starts to constrict, means there is RAPD. Alright? Now, light near dissociation, this means that the light response directly to the eye is impaired, but near response is much better. So where could the lesion be? So there are 3 locations. Number 1 is at the afferent pathway. I hope by now you know afferent is from where to where. So this could be lesions in the optic nerve, the chiasm, the optic tract. Secondly, it could be at the pretectal area. It's around here. Alright? So what happened is that in conditions like dorsal midbrain syndrome, paranoid syndrome, or Agar-Robertson pupil, you would see that the response to light is very poor. That when you ask the patient to look near, it like constricts very quickly. And thirdly, of course, the efferent pathway, the ciliary ganglion. This is the ciliary ganglion. It's just behind the eyeball within the orbit, and this can be caused by damage to the ciliary ganglion, damage to the postganglionic nerve with subsequent aberrant regeneration. Now, physiological anisocoria, this can be source of confusion as well. It's also known as simple anisocoria or essential anisocoria. It should be less than about 1 millimeter difference between the two eyes, but some literature say up to 2 meter is acceptable. The light response and the near response are both intact, right? And this was thought to be because of transient asymmetric supranuclear inhibition on the Edinger West Pole nucleus that controls the pupillary sphincter. When you on the light and off the light, to get the people to move, you would see that the degree of anisocoria in light and dark are equal. They don't change, right? And physiological anisocoria can be intermittent, can be persistent. They can even change size sometimes. Last time we saw the left eye to be smaller, but now the right eye is smaller. And they can self-resolve. But the biggest question is for you to differentiate physiological anisocoria from Horner syndrome. Of course, I do not do this, but if you are really in dilemma, you can use 10% cocaine, and then physiological anisocoria will dilate, but Horner pupils won't. Now let's move on to the abnormal pupils. All right, disease-specific abnormal pupils. Right, oculomotor nerve palsy or third nerve palsy, what you see is the pupil will have dilated pupil, they will have ptosis, and the eye is down and out, right? So the degree of the involvement depends on how much the nerve is affected. It can be partial, it can be complete, it can even be divisional. You remember there is a two division of the third nerve, right? But the main question when you see a third nerve palsy is, of course, whether the pupil is involved or the pupil is spared. Right. So I would say when you have a patient with third nerve palsy, the thing that you really have to worry about is whether or not there is become aneurysm, especially if it's in acute third nerve palsy. All right. So, whether or not the pupil is dilated, whether or not the ptosis is partial or complete, or whether or not the motility disorder is complete, I would suggest for you to still scan the patient. So the best is, of course, MRI and MRA, but CT and CTA can give equivalent qualities in terms of detecting aneurysm. But the gold standard of imaging is, of course, cerebral angiography. So bottom line, acute third nerve palsy, new onset, fresh in hand, so scan the patient. Now, let me just give you some scenarios, right? So what you would do if you see a patient like this. Now, I think this is the biggest and the most important question you would ask. If the pupil is involved, there's no question to be asked. Scan the patient, right? Now, vasculopathic means the patient has, either diabetes or hypertension or hypercholesterolemia of the patient is smoking that can affect the integrity of the blood vessels, right? So if the patient is vasculopathic and there is pupil sparing acute but complete third nerve palsy, okay? In this sense, some experts say that would just follow up because it's complete, and complete is usually ischemic in nature, could be secondary to vasculopathic. But for me, I would still scan the patient. All right, because you never know, maybe after that the pupil would start to be affected, and then only you see some changes on the pupil. Number two, the patient is vasculopathic, but it's chronic, and the pupil is spared, but it's complete third nerve palsy, meaning the ptosis is down, the eye is really down and out. So what can you do here? Scan or not scan? Well, I would say it depends. If you get this patient after, a few months of the condition, and patient reports that, oh, now the ptosis is a bit up, I can see a little bit if I look down like this, and then the double vision is not too bad, that it's improving. So maybe you can opt to not scan. You follow up the patient, you treat the vasculopathic issues, right? Finally, if the patient is not vasculopathic, that is no diabetes, no nothing, but the patient develop acute pupil sparing, partial or complete, scan the patient. Right, so Horner syndrome, I'm not going to talk too much about this. That's a long topic, and there's a lot of understanding that you have to do. This is also known as oculosympathetic paresis, caused by damage to the sympathetic pathway from the hypothalamus down to the eye. It's a three neuron arc, quite long, it just like travel down until the upper chest and then go up again. So Horner syndrome produces a triad of meiosis, ptosis, and anhydrosis. The pupils are small and they have dilation lag, which is very important. After constriction, they dilate very slowly. All right. Now, I'm not going to talk about the pharmacologic testing. That needs another topic on its own. Now, but please pay attention to the clinical clues that can help you to locate where the lesion is. If you see heterochromia iridis, where the Horner pupil is a bit hypopigmented, then it's possible that the Horner is already a long-standing or congenital Horner. If the patient complains of facial or neck pain, beware of internal carotid dissection, right? This is what we call as painful Horners. If the patient complains of double vision, probably you can suspect there is a lesion in the cavernous sinus. Well, you expect to see some cavernous sinus lesion as well as brainstem lesion. If the patient complains of ipsilateral anhidrosis, could be central or preganglionic lesion. If the patient complains of hand weakness or clawing, which is recent in onset, then suspect cervical cord lesion. Right, so if you look at these etiologies, it is divided into central, preganglionic or postganglionic. All of these cases would make you scan the patient. Alright, so if you look again, the problems can be right from the brain down to the neck and up again to the eye, right? So you need to scan the patient. Again, CTA, MRI, MRA, and then you have to include as well the neck and the upper chest. Now, a little bit about tonic pupil. It is caused by the damage to the parasympathetic ciliary ganglion that supplies the iris and the ciliary body via the short ciliary nerves. So it innervates the iris to cause constriction and ciliary body to cause accommodation. So following an injury of any kind, re-innervation of the nerve will take place. Just like any nerve in the peripheral nerve, they would start to heal themselves, right? So this is what we call as re-innervation. Denervation supersensitivity can occur by which the postsynaptic receptors are upregulated to facilitate reinnervation. They are made to be more sensitive so that they can heal themselves, right? So aberrant reinnervation or aberrant regeneration can happen that lead to the fibers that is intended for ciliary body end up targeting the pupil, all right? Anatomically, there are more fibers for ciliary body compared to the iris. But now because of the aberrant, there will be sort of like probably equal pupil fibers to the pupil equals to the ciliary body, right? So this will produce light near dissociation where the response to the light is very poor, but when you ask the patient to accommodate, they can do that very quickly. Okay, now have a look at the pharmacologic testing. You can use pilocarpine, which is commercially available. You can use the 1% and dilute it with water for injection to make it 0.1%, and then instill to the lower cul-de-sac and wait for about 45 minutes. And then tonic pupil, you would see that they would constrict markedly. Normal people, if you put this very small percentage of pilocarpine, they will not do anything. But because of the denervation supersensitivity of tonic pupil, they would constrict. Now, what are the causes of tonic pupil? The idiopathic cause is called Addis pupil. In Addis pupil, you will see more in female and usually it's unilateral. Tonic pupil can also be caused by viral infection, trauma, or vasospasm due to migraine. Now, what are the symptoms? Patient can complain of blurry of vision, but they usually complain of photophobia and difficulty with reading. What you would see on examination is, of course, a dilated pupil. You will see light near dissociation. You will see slow redilation of the constriction. And then if you put the patient at slit lamp, you will be able to see some sector paralysis or vermiform movement of the iris. So how do you manage? Well, most people wouldn't need more than just reassurance, but some would need reading glasses, but some would also need contact lens for aniridia. Recently, I saw a patient who is a young patient. He has so much of photophobia, but he could tolerate well with the aniridia contact lens. Now, a little bit about agar-Robertson pupil. Do not freak out when you see patients with very small pinpoint pupil. It can be irregular in nature. They have light near dissociation as well. But unlike tonic pupil, when they can redilate briskly after you shine and then you let it rest, it can redilate very quickly. So where is the lesion? The lesion is can be at the rostral midbrain area, affecting the pretectal fibers. but sparing the adenogen nucleus that controls the near reflex. So conditions like neurosyphilis can give rise to this. Diabetes as well. Most patients are elderly. They have diabetes. When you shine, their pupil is very difficult to dilate, right? And some neurosarcoidosis cases as well. I think that's all. Yeah, that's all. Thank you.
Okay, thank you, Dr. Fadila, for her presentations. It was very informative and it's very clinical based on the approach to pupil abnormality. I think, especially for Part 2 trainees in the master program, you need to know this in and out. And when you are examining, when you are dealing with N-isochloride particularly. So, I think we can allocate some time for question and answer, maybe 5 minutes. Whoever have any questions, maybe you can channel to the 3 speakers, other than those who already asked their question and has been answered by the panels in the chat room. So those who wants to straight away ask, you all can ask.
Okay, Henry.
Yes, Rocket.
Okay, I jawab ada 2 question yang tak sempat jawab. I cannot type in, too long lah.
Oh, okay, sure.
Okay, satu is question tu pendek je. Apa ni about plasmapheresis in ophthalmology. Okay, to be frank to you, those who interested to know, sebenarnya I personally pun tak pernah pakai, tak pernah gunalah untuk this method, because from the study that been done, most of the patient, yes, of course, they tak respond very well. What they call it refractory ophthalmolitis. But most of their patient is due to MS. Is a typical punya ophthalmolitis lah. Sedangkan kita punya patient is atypical. So we still need to investigate further to find out the cause of our patient punya cause of ophthalmolitis, and then try as much as possible to treat dulu, because usually kita reserve dululah. So far pun I tak pernah try, tak pernah ada experience. Kalau Dr. Fadila ada, I tak pastilah, mungkin boleh tambah lah. But most of the study yang mention, the response so far okay, quite good, but most of the patient is actually MS patient. Jadi kita macam tak straight to common use yang diorang pakai lah. Jadi kita kena justify properly. So that is the first question. Second question, when we want to do MRI in cases of suspect NMO. Okay, like I did inform just now, kita take as general lah. We are not doing MRI in all cases of ophthalmolitis, but when we suspect there's something awkward there, something is beyond what the possible cause. Okay, then the presentation usually apa dia? Bila patient presented with CNS punya problem, itu we need to do lah. Then lepas tu, kalau kita still suspect there's something not right, yang tu need some experience lah after the discussion with the senior. Then lepas tu you tengok lah, because we don't need to do in all cases. We have few cases yang presenting like MS punya features, then it turned out to be NMO. So you can send for anti-aquaporin 4 antibody, but sometimes it may take quite long to get the result. You can justify to do spine punya MRI, if like say patient punya symptoms tu quite prominent, so that you boleh justify. Otherwise, usually kita tak buat lah. So again, if you able to recall just now, kalau kita ada suspicious of patient with MS, sebenarnya our patient kalau 3 patient sebenarnya NMO, 1 je patient yang multiple sclerosis. So you boleh fikir untuk proceed further with spine later. Usually kita ask for anti-aquaporin 4 antibody dulu. Okay, thank you.
Thank you, Prof. Wan, for answering the questions.
Ada lain-lain? Tak ada.
Ada yang put in a case in the chat room. I tengah baca juga.
Oh, ya. Kalau case patut bagi tahu je.
Yeah, there is a case.
Assalamualaikum, Prof.
Waalaikumsalam.
Okay, and good afternoon, everyone. I have a question regarding giant cell arthritis. Last time we got a referral from medical department for a patient who's proved to have giant cell arthritis based on temporal artery biopsy, referred for eye assessment. At that particular time, patient did not have any ocular manifestation related to giant cell arthritis. In particular, there is no arthritic ischemic optic neuropathy. So my first question, how frequent we need to follow up for this patient, giant cell arthritis without ocular manifestation? And number 2, is there any role of prophylactic steroid that should be commenced by the ophthalmologist in order to prevent from development of AION? That's all. Thank you, Prof.
Okay. Very good question, but difficult to answer because like I told you, satu, kita tak banyak patient. Kalau you ada patient pun, is considered very, very rare. Dan I think most of our patient already been diagnosed with giant cell arthritis on follow up with medical punya ni. Dan what you need to do is to, macam tadi lah, sama lah, review patient regularly, warn the patient. But I think we can't predict so far macam mana patient akan develop. To start patient on steroid usually depend on the main problem yang ada. Kalau they want to assess the patient need to be on steroid, then it's okay. But for us to start steroid to prevent from arthritic AION, I think is difficult to justify lah. Unless patients start having some problem, you can see already some changes in the optic nerve. The most important is actually you monitor dia punya field lah, visual field. The visual field can show you early changes. So if the early changes tu dah start ada, then you are more convinced that is the changes due to ischemic optic neuropathy, then most probably you can start early, low dose lah, kalau patient not on steroid yet. So that is what I can advise lah. So far most of the times like sama condition yang you are facing, kita not receive the patient straight away with ischemic arthritic ischemic optic neuropathy, but it's already been proven. So what we can do is to follow up the patient, inform the patient the complication, then we try our best to make sure that we are able to monitor so that kita boleh detect early changes. Itu je lah yang boleh boleh dibuat at the moment lah. So I hope I can answer your question.
Okay, thank you, Prof.
Thank you, Prof. Wan, for the answer.
Cuma I nak tambah satu, like our patient previously, patient may develop other complication also of GCA to the eye. Jadi you I think regular monitoring and make sure that patient really aware that if there is any other problem, so dia complicated sikit lah. So okay, good.
Thank you,
Can I
Prof.
just chip in a bit?
Yeah, sure, Dr. Fadila.
On my experience managing arthritic AION, I am still seeing a patient who is an old man who developed central retinal artery occlusion (CRAO) plus INO, and then he was investigated, and the CRP was initially we did ESR. ESR wasn't too high, and then we did CRP. CRP was high, and then we did platelet. And then platelet also was high. So you would do these three things to see whether this is arthritic or non-arthritic AION. So, and then we proceeded to do a biopsy, and it was proven to be positive. So, in a way, I was relieved because it was positive. So, you can go on to start steroids. So, what was then? The patient was started on IVMP for 3 days, and followed by an oral steroid. Now, I just want to highlight the scenarios that you might face. This patient, even though we put him on steroid, a few months, about 3 months later, he developed PION on the fellow eye. So the first eye became blind, and now the second eye, despite the steroid, he still loses the vision. And because of the steroid, he developed a lot of problems, PCP, pneumonia, he developed GI bleed. So it was so difficult to balance between the two, The steroid level was reduced because of the complication, and while the steroid was a bit reduced down to 30 milligram, he developed the PIN on the fellow eye. And then a few weeks later, he developed nerve palsy pula. So it's like, oh my God, it's like so many things. It was so difficult to manage, not just the primary disease, but also the steroids on elderly patients. But what I want to highlight is that even though it's very rare in Malaysia, like what Prof. Wan said, yes, but once in a while you might see this patient and you might miss it.
Okay, thank you.
Okay, betul tu. So sebenarnya if I may say that you tak perlu banyak-banyak patient GCA, you ada satu pun you cukup penting lah. Seperti yang Dr. Fadila counter lah. It is very challenging. It's not only about anterior ischemic optineuropathy. It's so many other things lah. So that's why you have to see all the possibility bila you manage the patient. Try to balance up between the treatment and also complication. So we are considered quite lucky. We don't have so many patients with GCA. Otherwise, it's very challenging. It's not that straightforward. Okay, mungkin Dr. Ain nak tolong jawab soalan yang last tu. Anti-cooperating for investigation, do we need to do all? And maybe you can touch a bit mock punya ni sekali investigation. Ain?
Okay, hi Faisal. Normally we are not routinely encouraged to send coporin for all cases of optic swelling. So based on our assessment, if let's say it's clear-cut infective or autoimmune causes, so probably we can treat first. Only if let's say it is suspicious for NMO, for example, if it is poor recovery or whether it is a recurrent cases, probably that is indicated lah. Similar with mock, mock normally we respond quite fast with steroid. But then if there's a recurrent episodes of optic neuritis which you suspect to be mock and need further long-term immunosuppression, so we can send to confirm. And we have a combo package to that link, 750 ringgit for both aquaporin 4 and mock. In government setting, in IMR, they also doing, but it takes quite some time lah. If we want to wait for the result, it takes about like 4 to 6 weeks, if I'm not mistaken. But I'm not sure the latest status. How is the latest status?
Okay, kat situ last apa ada Alphagun NAION. Okay. So far I don't have any experience about that. I pun tak pakai sangat. Mungkin new one. Kalau nak try tu boleh lah. Tapi so far tak ada study yang proper lagi. Mungkin in future kita tak pastilah. So actually a lot of new things coming yang we still need to update ourselves. I can't answer everything because we are still orang kata satu cases kita tak adalah banyak sangat, then kita tak boleh nak buat a lot of trial apa semualah. We are so far following the standard punya ni, and then a lot of cases are very challenging, then it really demand the extra punya investigation lah, especially to find out what are the possible causes. So I think okay kot, setakat tu je lah dulu. Thank you so much to everyone who able to attend this one. I can see the participants still maintain towards the end walaupun few left. It's okay actually. Masing-masing ada tugas masing-masing. But thank you very much for wait until until the end lah, consider. I know there will be a lot more question. Maybe in future we should have more session in terms of Q&A so that you all can ask more question. Then we are trying our best to help you all, especially in terms of management. I know neuro ophthalmology cases is not straightforward. It is actually very challenging. Then you might need some help untuk managing your cases. So thank you very much, Dr. Fadilah, for joining us with a very impressive punya talk. Tapi Dr. Fadilah nampak macam garang hari ni. Thank you for your very informative punya talk. That we appreciate you able to join us. Dan Dr. Ain is actually coming to the end with me already. By end of this month,